Good afternoon, good evening, and also good morning to Europe. Hi, Bob. How are you doing? Good. Nice to see you. And I like the little puppy over there with you. All right. We are continuing our session today. This is our third week, and we are going to have exercise and metabolic diseases. And I believe this session is being chaired by Dr. Norhayati from Brunei, a very good friend of ours. And I think we have together quite a handful of people at the waiting room. I think they all have came in already. We have about 100 and how many room one?
Room 141.
25.
We have 120 over people in the room. So I'm not going to delay anymore with you guys here. I know some of you are at different time zone. And I know, Bob, you are having a huge election next tomorrow, right? So, all right, I'm going to pass over to Dr. Norhayati to carry on to chair the entire session of today. So welcome again back to the World Conference on Exercise Medicine. Thank you.
Assalamualaikum, and a very warm welcome again to our conference participants. And it is my pleasure to moderate this session today and introduce to you our speakers for this session. At this juncture, may I remind all speakers that each of you have about 30 minutes for your presentation, 20 minutes for your presentation, followed by 10 minutes of questions and answers. So without further ado, may I introduce our first speaker for today, Dr. Robert Nello Girandola, who has a Doctor of Education degree from the University of California at Berkeley, and has been teaching and doing research at the University of Southern California since 1973. His research interests are focused on obesity and solutions, sports nutrition, ergogenic aids, and environmental factors in human performance. Dr. Girandola will be speaking about the global obesity epidemic, which I think is a very appropriate introduction to our session today. Dr. Girandola, I now hand over the session to you, please.
Good day. My name is Bob Girandola. I'm an associate professor in the Department of Human Biology at the University of Southern California. And I'm happy to be presenting this video for the International Conference on Health. And my topic is obesity, the global epidemic. Let me try to explain a couple of things. My research areas have been primarily in fitness and ergogenic aids, body composition techniques. I have not actually done data collection so far on obesity and cures, etc. However, I'm very interested in this topic. I teach it and I talk about it. I have given conferences about it. I've read as much as I can about the efficacies of drugs and other methods to try to cure this thing. Unfortunately, it is really in epidemic levels. There's nothing else you could possibly say. It's a topic that seems to never, ever go away. I'm older. I grew up in the 50s and 60s in New York, and it was a whole different world at that time. And I see the things that are going on now, that the size of people have changed, morphology. It's really a remarkable thing, especially if you've lived a long time. If you just grew up in the 1990s and 2000, you don't really see things that go on that are changes. Anyway, let's talk about obesity, etc., and the topics, so to speak. The first slide shows the categorization of obesity, how it's classified. They use a body mass index categorization of height, weight in kilograms divided by height in meters squared. For the most part, if you're somewhere between 18 and 24, you're considered normal. Anything below that, you're underweight, but the problem mostly is in overweight. 25 to 29 is considered overweight, and then 30 and above is obesity. And there are different levels of obesity, because you can see on the slide that it comes up. When you get into 40 and above, those were usually classified as morbid and super obesity. The next slide, interestingly, shows an Asian BMI on the right-hand side. And you can see that the Asian BMIs are somewhat lower in terms of the numbers before you classify that. I think part of the reason for that is that in Asians, generally, there is less amount of fat-free mass. And the reason that's important is the fact that Asians tend to have less fat-free mass, and fat-free mass is unfortunately, fat-free mass is a higher density than fat. However, there are a lot of people that argue, well, maybe BMI tends to overestimate the level of obesity because there are a lot of individuals who are athletic and have a lot of fat-free mass, and they are misdiagnosed in terms of their height-weight categorization. As you can see from these slides on the male, same height, more or less maybe the same weight, but different levels. Same thing with females, same height, same weight, but you can tell the female on the right, as you're looking at that, certainly looks a lot different than the one on the left. Again, does it distinguish between fat and muscle? I have done enough athletes at my university to know that a lot of these individuals had BMIs approaching morbid obesity, and yet these individuals were low in fat. You can look at this picture here on the male and female side, and the top row shows very muscular individuals on both males and females, and as you slide down, you see individuals with a much greater proportion of fat on their body. What I can tell you emphatically is that the number of people, whether you look nationally in the United States or globally, the number of people who are misdiagnosed because they have excessive amounts of muscle mass, because they're athletic, either genetically or by training, I can safely say, without any doubt in my mind, that those individuals make up a very, very small portion of the worldwide population. So more or less, if you have a high BMI, you're probably going to have a lot of body fat. Now let's look at trends. Okay, so we can see over here on this slide here that shows from 2007 to 2016 severe obesity rates among individuals, and that's talking about BMIs of 35 to 40 and above. And those numbers have increased dramatically, both for men and women, but it looks like for women, the effects are much, much worse. This is the real scary one. Again, this is United States data. And you can see overweight, which is 25 to 29, is somewhat steady from the 1960s, although it's gone up. Statistically, I think there are probably about 65% of the population in the United States that are overweight. Women seem to be slightly lower than men in terms of the actual percentages. However, when you look at obesity, which is 25 to 29, 30 and above, the obesity values you can see from the 1970s, they basically have gone up dramatically. I mean, really dramatically. So they represent maybe as much as 35% to 40% of the U.S. population. And then down below, you see extreme obesity. Again, these are the categories which would be normally classified as 40 and 50, which are morbid obesity and super obesity. And those values have really increased from a very, very low number in 1970s to at least 5% of the population. That's a 5-fold increase in terms of those numbers. That's quite scary. This is again a show of the population, both now, what is even worse than adult data, to look at children, because children have been steadily climbing. And I know when I was growing up, a little fat child was considered to be actually ideal, cherubic, cute, and etc. That's not the way we look at it now. Fat children become fat adults. I mean, this is the reality of life. And that's why when you see a lot of obese children, it's really a very frightening situation. This is why being fat or obese by BMI standards are so critical. When we look at the relative mortality rate on the vertical axis versus the BMI category, you can see that once the BMI passes 35, the risk of premature death increases exponentially. I mean, really, really high. When you get to 40, which is morbid obesity, there's a reason for that. Usually the person dies of cardiovascular disease or maybe something else. It's really very, very bad. So we do know that if you have a lot of excess weight, which is usually excess fat, you're not going to live very long, especially when you go above 40 BMI. This next slide shows the worldwide, the global total number of deaths by risk factor. And you can see at the very top, hypertension or high blood pressure is the highest. Smoking, which is another one that's curable. I mean, it's a lifestyle. And then high blood sugar, which is diabetes. Air pollution and obesity is right there at almost 5 million people dying in 2017. We're faced now with an epidemic, COVID, the viral epidemic that's affecting everybody, in terms of the number of people dying. 1 million in about, 6-7 months is really a catastrophe. But obesity is something, it's a lifestyle more or less, that is something that people can do something about. But unfortunately, they keep getting worse and worse and worse. Why do people get so fat? And why is there such a trend? Well, very simple rule of thumb, and it's all strictly mathematics. We have a balance of calories. We expend a certain amount of calories, as you can see on this slide here, calories out on the seesaw, and then you have calories in. It's quite easy to measure calories in because unless you do intravenous, anything that passes your mouth is calories, whether it's food and drink. So we can calculate that. Caloric expenditure can also be quantified, but to measure it on a 24 or 48-hour basis, you have to have a special device. But we can estimate what that number is. So if you want to lose weight, have a negative caloric balance, you have to eat less than you're expending, which you see on the middle slide here. That's caloric deficit. And if you end up consuming more calories than you expend, you're in positive caloric balance and you're going to gain weight. And for the most part, globally, that's what people have been in. We've been in a positive caloric balance for a long, long period of time. The next slide is just another one. What determines your caloric expenditure? Well, resting calories, how many calories your body needs. Every cell in the body is like a small factory, so it uses energy. The more cells you have, the more energy you're going to use. How much activity and exercise, I don't know why they put it separately, but activity and exercise, maybe because activity means walking to the store or climbing stairs to get in and out, doing housework or something like that, as compared to exercise where you have formally go to a health club or you formally go out and run or swim or something along those lines. But I put them all together. Caloric expenditure by activity, caloric expenditure resting. What we've done in our laboratory is basically, for the average person, resting metabolic rate is the critical one because for the most part, assuming the individual is not a competitive athlete, resting caloric expenditure represents about 90% of the total calories. Obviously, you can modify that by doing a lot more activity, but unfortunately, it's very difficult to do. When we look at the United States, which we have a lot of data about on, and also I'm very familiar with it, if you look by states on this obesity trend from 1990 until 2015, which is a 25-year period, you can see that this is a chart that shows the number of the percentage of individuals who have a BMI of 30 and above. So what you can see here is that the one on the upper left, the 1990s, there are basically, most of them are between 10 and 14%. I mean, that's all it was. It was only a few states that were a little bit higher than that. But you go 9 years later to the one to the right of that, and you're starting to see a dramatic rise, especially in the southwest and, the southeast and the south. You're starting to see that tan color, which is 20 to 25%. Now you move another 9 years later to 2008, and you start to see that there's only one state, which is Colorado, which doesn't have a high population, that is, less than 20%, and all the other states are much higher. And then 7 years later, in 2015, which is, 5 years ago, you start to see really high levels. In fact, I believe it's Mississippi and I believe maybe Georgia, I'm not sure, Alabama, have over 35% of their population of being obese, but all the states are affected. I mean, this goes to show that it's a steady climb that seems to be insidious throughout the United States. This is the projected rate. This is the scary, scary thing. The projected rate, which is only 10 years from now, I'm sure they made this projection some time ago, of how many people be obese. And you can see here what they predict is that in those southern states, again, Mississippi, which is considered one of the fattest states of the population in the United States, and Georgia and Alabama and Oklahoma, etc., all of those states generally tend to have, they predict that they're going to have in 10 years, 60%, more than half of the population being obese. They didn't do anything about looking at the massive obesity, severe obesity, but I'm sure those numbers are going up there. Why those states specifically tend to be worse than others, I have a potential reason why that's happening, as you're going to see from the data later on. But there's no doubt that the United States is getting fatter and fatter and fatter. People in this country here are big time fat. And I mean, as I say, I've been around a lot of people for a long period of time. I grew up with sports and being outdoors all the time. But nowadays, you know, people like to be inside and they don't know what it's like to be out in sports. This is the global picture as well as the United States. The United States always leads in the worst possible things. So in terms of obesity, you can see this is BMI in high BMI values from 25. You can see that the top lines represent men and women in the United States, and then the blue lines below that are the global population. But the sad part about this, and I think anybody pays attention to this COVID-19 virus problem, that they're always talking about flattening the curve, reaching some kind of asymptote at being the big thing so that there's no more increase in numbers. But here you can see there's no flattening of the curve. That curve is absolutely going up no matter how you want to cut it. It's definitely going up. There is no plateauing ever in any of these things. This is the prevalence of obesity both in children as well as adults. And again, you can see that the data from 1975, which is the dark color with gray, whatever you want to call it, as compared to the green color, which is essentially about 40 years later, you can see the numbers are dramatically. And again, women seem to be higher in body fat in terms of BMI than men. Why? I can't answer that, but that's what happens. When we look at obesity by race, there also seems to be a difference. It looks like non-Hispanic black population tends to have a much higher concentration of obesity, although not necessarily extreme obesity. We start to see Hispanics also higher than whites. Some of that may be culture, some of that may be education, some of that may be income. But whatever it is, it's definitely a factor that occurs there. In the non-Hispanic Asian population, again, in the United States, it's still pretty low. It's 12.6%, and there are no cases of extreme obesity. That doesn't mean it's not going to happen, but as I say, at least there, the Asian population in the living in the United States is a little better off. These are global populations, and you can see here it's the National Collaboration for National Cancer Society, etc. When you can take a look at these, and again, the darker shading indicates the higher number of BMI cases in the men in the global population, and you can see that Australia, United States, southern part of South America, in the Middle East, the male population is quite high in terms of the obese population. I mean, this is just the way it is, a high number of people who are obese. And then if we take a look at the women, more or less the same trends. You know, it's basically high all the way across the line. We have BMIs of 30 and 33, again, in south part of South America, in the Middle East, United States, and also Alaska. People are getting fat. This is the total number of obese adults in 2016. You combine men and women together. And again, you could start to see overweight. I'm sorry, this is 25 and above. So again, you see a lot more because 25 is not that dramatic. If you take a look, if you're used to English measurements like I am, height, weight, a person is 5'7" and 160 pounds, which is not that bad, is really overweight, you know, by a few percentage points. But somebody who's obese is a lot more. So the number of overweight people is dramatically higher. All of Russia, some parts of even Canada and South America, and all these populations also. And this is the craziest part. When you look at children who are overweight, it's just remarkable. As I say, I grew up in a different environment. I grew up when people were outside playing sports all the time. There was nothing to do inside the house. Television was more or less in its infancy. We had 5 channels, and it only came on at night. so we could be outdoors all the time. And I grew up in a neighborhood in New York City, not exactly in the countryside, and I was outside all the time. My mother had to call me in when I had to go in. But we didn't have computers, we didn't have internet, we didn't have PlayStation, we didn't have TVs with cable with 150 channels that are on all day long. So we grew up looking at sports, etc. Now, as I say, you have to kick people out of the house to get them outside. And this COVID variation that has come about and has kind of forced people to be more sedentary, this is a really bad situation. I mean, it's been basically since about March that people have been forced to stay home. And if you live in a metropolitan area, it's a very difficult thing because gyms are closed. And that's been like over 6 months of that situation. Okay. The share of deaths that are attributed to obesity as of 2016, you can see that Russia, northern part of Africa, middle, South Mexico, and depending on what you're looking at, the northern part of Africa and a lot of the Middle East, etc., all of these places have a high incidence of premature death as a result of being obese. Now, when we look at the caloric balance, the fact that people are in positive caloric balance over many years, there's a reason for that, okay? Either you're doing a lot less activity or you're eating too much food. And people have tried to identify one or the other. Which one is more important than the other? I'm assuming it's a combination of both. I'm one of these people that really harp on exercise. I mean, when I teach my classes, I'm always telling students, you have to move. You have to do exercise as much as you possibly can. This chart here, as you look at the United States, shows the self-reported physical inactivity among U.S. adults in 2015 to 18, so not that long ago. And as you can see, the states of Mississippi, Louisiana, Alabama, many of these states that you can see there, including Texas, high levels of inactivity. And those are the states that have the highest level of obesity. There aren't too many states here that you can lead that are in the green. Colorado, Utah, Oregon, Washington State, that people are much more active. But the fact is that people are just lazy. They're sedentary like crazy. So they're basically doing much less activity. I always remember when I read a story about the most popular physical sports, the recreational activity that people do. The top 5, I remember, among the top 5 was bowling, billiards, and golf. Now, bowling and billiards do not require any physical activity. And you spend 2 hours, 3 hours worth of bowling, you're not burning any calories at all. And the same thing with billiards. Golf, yes, if you walk 18 or 36 holes, you are burning calories. But when I walk by a golf course, I see people in golf carts and riding from hole to hole and getting up to hit the ball. That's not caloric expenditure. Again, years ago in the 1980s, studies at Harvard University linked children's obesity with the number of hours watching TV. This is compounded by the fact that people are much more in front of a TV. There's so many channels that are around. I find myself, because of this COVID, that I'm watching a tremendous amount of TV and I'm on my behind all the time. But I actually do my exercise in the morning. I always make sure I do something. These people don't have the same kind of desire to exercise. There's no really feeling for it. But you can see on this chart here, a large number of children are watching TV an inordinate amount of time. Parents maybe just put them in front of the TV and say, okay, forget about it. But unfortunately, adults are doing it also. You have a remote. You never have to get up out of your seat, and you can watch TV until you're ready to go to sleep, and that's the end of it. This is the global inactivity. So it kind of mirrors the level of obesity that you see. In the Middle East, very inactive. In some parts of South America, very inactive. In Australia, very inactive. Again, I'm not going to post it just on that, but certainly a lot of places in the world, people are much less active. Since cars became very popular and very commonly owned in the United States, I can say post-1970, a lot of people were able to afford cars, and people drove everywhere, even to the supermarket, to the post office, everywhere. I mean, you could understand you have to go to work, and the work maybe is 10 miles away. It's a little bit far. But nowadays, people drive everywhere. And unfortunately, the mentality is that people don't think that they have to walk. I mean, when I was growing up, it was not uncommon for my parents and I would go to the supermarket, and supermarket was maybe half a mile away, and we'd go back and forth. It's nothing that we would think about. Nowadays, you would never think about having to carry bags more than a block. And some people don't even want to carry it out of the store. They want a car right at the edge. And again, physical inactivity also in the United States seems to be also in ethnic varieties. You find the highest amount of inactivity in African Americans. And also, if you notice the slide before, there was a higher level of obesity in African Americans. Hawaiian, Pacific Islanders, Hispanic, etc. Asians seem to be the most active, as you can see on the far right-hand side of the slide. So activity seems to be correlated somewhat, or lack thereof, with obesity. It's not one-to-one, of course, because no matter how active you are, if you eat too much, it's going to be an issue. So looking at the reductions of activity levels in the workplace, you can see this here. Moderate level of activity, which is classified as METs. 1 MET is the amount of energy you use at rest one time. So anything that's a factor of that, like 2 METs would be twice the amount of activity. 3 METs is still pretty active. So you can see people doing light activity is increased, but people doing moderate activity has gone down. And this is typical because in factories now, robotics basically does a lot of the physical work. Many people are basically glued to their chair on a computer rather than being on the front lines, lifting or carrying, etc. So while technology has been a great, great thing for the world in general, it's unfortunately created a massive problem. This is again to show the amount of obesity in children and youths, and it continues to go up for both children and adults. One of the things I always remark that first time I was in China, in Beijing, for to give talks with my department. It was 1985. And it was quite quaint because we got to Beijing, they picked us up by car, and they drove us to the university. And everybody was riding a bike. You saw very few cars around. This was, again, 1985. Nowadays, very few people, because I've been to, not Beijing, but China, I've been to Shanghai and several other cities in China, and you see very few bicycles on the road. Now people drive cars everywhere. Their economy has increased dramatically. They've been able to afford cars, and they feel it's their right to own a car. But unfortunately, while their economics have gone up, the cases of obesity has gone up. And last statistics I saw, that 25% of the adult Chinese population is overweight. And that's like 250 million people. That's an enormous number of people that tends to be overweight. These are the least physically active countries. Again, where this data comes from, I can't speak, but it is on the internet. But you see the Middle East, Kuwait had a high level of obesity, Saudi Arabia, Iraq, and of course the United States is right up among them at 40%. But the Middle East and some parts of Middle America, it's in the middle of between South America and North America, also very high. And the countries that are most physically active, countries in Africa and of course China. Although China has gone down dramatically from when I was visiting there before. But as I said, as the economy gets bigger, it is bigger. So I don't have any doubt in my mind, even though it may be subjective or just based upon data of personal observation, people are much, much less active than they ever were before. Look at the modern conveniences. You have robotic vacuum cleaners. You don't have to do that. You have toothbrushes, although that's pretty minimal, that you don't have to move your arm to do that. Now you have these so-called things like Alexa, that you basically sit on your behind and just by voice you make the robotics, change the lights or do this or do that. Anything to make sure people become totally sedentary. And that becomes a major problem. Now, this is not necessarily to eliminate the caloric intake. The U.S. Department of Agriculture has indicated, as you can see from this slide, that the average, you can't see from this slide here, the average consumption since the 1970 to about the present day, the Americans are consuming about 500 extra calories per day. That certainly would account for the massive increase in weight. Where those calories are coming from? They're coming from, unfortunately, that's not the slide I wanted to show, but the slide that I'm going to show would be the amount of fat that people are consuming. A lot more added fat to foods like potato chips, French fries, etc. And then also refined carbohydrates, a lot more sugar that's being consumed. Those are definitely issues that are coming out. I said at the end of my abstract, that I have a very gloomy picture of the future in terms of this. We know what the answers are. Become active, eat less food, but it's not going to change. I base my opinion, my prediction, based upon this. You look at this thing here. I'm sorry, this is the daily calories that people are consuming. You can see people in the United States, UK, and some European countries are consuming much, much more calories than before. But this is the reason of my prognosis. If you take a look at the trend lines, again, no plateauing. From 1970 to 2020, it's a 50-year period. There is no plateau. Every country, you see an increase. Some not as dramatic as others, but every country is involved. More of the same. You look at obesity, remember 30 and above, over a 50-year period in the United States. Again, do you see any plateauing? None whatsoever. Obesity and also very obese people going up all the time. Again, you look at obesity rates by country, with maybe the exception of some Scandinavian countries like Switzerland, Sweden, etc., and Korea, maybe not quite as dramatic a rise, but every other country is going up. I wish I was better, I would feel better, but look at these numbers. These are projections. Projection is that we would be up, the United States would be up around 40% of the population being obese, and 27% globally. It's not a very pretty picture. I wish I could say differently, but unfortunately, it's not likely to change. I mean, people are just getting obese. They're not going to change unless something dramatic happens, and I don't know what that is, because in our country, United States, it's only like at the local level. People try to do something by state, but there's never been like an integration of what to do nationally about this problem. As I say, I wish I would be a lot more optimistic, but I can't be. And I leave you with this. I wish people would be more active and eat less food, but so to speak. I hope everybody else has a good outcome from this covarious, and I hope maybe I can come to Malaysia again as I was 2 years before and enjoy myself in Kuala Lumpur, wherever that happens to be. I wish you goodbye. Ciao. Have a good rest of the week. Bye-bye.
The reason why the BMI has been questioned, you saw this slide, the exponential curve that increasing mortality when it gets above 35. Again, this is only because high BMI is associated with high body fat. There has been no evidence that I've ever heard of to indicate that somebody who has more muscle mass is more at risk. I think somebody mentioned about professional wrestlers. Now, unless you're talking about sumo wrestlers, which definitely have a lot of body fat, there's no reason that I could think of that the BMI of a wrestler should be a risk factor in terms of cardiovascular disease or cancer or anything like that. So weight is not the issue. It's body fat that's the issue. Yeah, solution is that's a good question. Again, I keep talking to my classes all the time, and I'll give you a little quick synopsis. I was teaching a class one time, and they vary where the classroom is. That was on the second floor, and I never take the elevator unless it's like in a skyscraper. So I saw some of the students in my class waiting for the elevator, and when I got up to the room, I said, I'm a lot older than you guys, and I take the stairs. And I wanted to kind of shame them. So the next day, that I taught the class, the people were still waiting for the elevator. It had zero effect on their psyche. Again, I wish I could tell you why. I love to exercise. I mean, I know some of you do that exercise all the time. When I was a graduate student at Berkeley, my friends and I, we used to run in the hills and everything. It's a great feeling. But how do you get that same kind of feeling to that like this? Again, in our country here, we have a Costco shopping center, which I love to shop at, and they have really big parking lots. And these people, they park right next to the entrance, or they wait for a spot to open up because they're afraid to walk maybe 100 meters to get to the park. It's just mind-boggling. And in my country here, it's you have individual states, etc. If there was a national mandate to say, you're going to get some prize or something, maybe give people an incentive to get in better shape. I don't know how else to do it, because at the individual level, it's just not going to work. I mean, I see people all the time in some of these states, you see pictures on the news, etc. And these people just are enormous, and there's no shame. As I said, I don't understand it, but it is what it is. One of the things that they associated, that Mississippi is the poorest state in the United States. And they indicated that, I can't remember the exact statistics, that this was a few years ago, that the average obesity was something like 25% in these people who have a family income of $15,000 a year. That's for a family, $15,000 a year. That's like about $1,200 to $1,400 a month, which is like nothing at all. If the income went up to $50,000, the obesity rate dropped down to about maybe 15%. So there seems to be something along those lines. Also the fact is that we talk about it among the students, that when you live in a poor area, the type of food that you have available, you're much more likely to buy potato chips and corn chips and crappy foods to fill your stomach up because you're hungry, rather than eating fruits and vegetables, which would obviously be a lot better. But that's the way it is. And as I said, I mean, people have looked at every possible avenue. In our country here, and I'm sure because last time I was in Kuala Lumpur, I forget where it was. It was in the horse thing, the hotel. I went to the shopping center, the mall, just like the United States. At the top floor, they had all of the eating malls, etc., everything you could have. And right underneath that was all the video games. And the kids were all doing that, just like in America, the same concept there. It's just something that is really hard to change. McDonald's, all these fast food places, the way they get you, they try to increase the amount of food that you get. I mean, I'm sure some of you have seen advertisements for these fast food places. I mean, pizza. I'm Italian, even though New Yorker. Pizza in Italy is like tiny little thin pizza crust with a little bit of cheese and a little bit of thing. If you have pizza in the United States, it's like gigantic big pieces with much cheese on it. They even stuff cheese inside the crust. I mean, anything to increase the volume of food. And that's what gets people going, because people think, well, rather than spend money on a small amount of food that might be good for me, I'll pay something that is bigger and bigger and bigger. And that's how they rope you into it. And unfortunately, when people get into the habit of eating large amounts of food, it's very hard to change that perspective. For kids, they have to. I'm not dealing with young kids, but I've always told people, do something that you like. If you force yourself to do something where you have to run, some people don't like to run, especially some girls. They don't like to get sweated up and everything. I tell them, do something. Walk if you have to. Get some friends and walk around, etc. Anytime you get the opportunity to walk or do something physical, if you live on, or you have to take go up maybe 4 floors, take the stairs instead of taking an elevator. If you go to the airport, don't take the moving walkway or the escalators. Take walking up the stairs, etc. I go to LAX, Los Angeles Airport, and just my observation, I watch people, and the first thing they do, they get to the gate, they want to sit down, and then they eat. They don't want to walk around, and they're going to get on a plane for maybe 4, 5, 6 hours, and they're going to be sedentary again. It's difficult. It's a mentality that it's very hard to change. And unfortunately, this COVID has probably affected you people also. People are stuck in their houses for literally since the middle of March. And they closed the gyms where a lot of people go to. I live in a pretty rural area, plus I got the treadmill behind me. If I don't do exercise in the morning, I don't eat. You can imagine how my wife feels about that. I'm kind of psychotic about it, but this is just me. But again, kids, you got to get something that kids like to do. Make it enjoyable for kids, however it is. Where I live, again, it's the kids are outdoors a lot. It's kind of a rural area, so they kind of like it because the parents are doing that. But I tell you one thing. I mean, in places like I've been to Las Vegas before. I don't know how anybody's been to Las Vegas, and that's a really bad place if you're trying to lose weight, because they have gigantic buffets and people eat continuously, and nobody walks. Nobody does anything outdoors. And by the way, even though it's only the last 3 years, we have somebody in the office right now, of the highest office in the White House, who eats horribly, never exercises, and doesn't care about the health of the people, unfortunately. When you have somebody like that, that sets the goal. And if you ever see the people that come to his rallies, they're all like him, like that. You can tell what my feelings are. What I told people, because they asked me this for school, because they wanted my opinion. If people are stuck in the house, I don't know, who knows how long this pandemic is going to last. I tell people, get a stationary bike. You don't have to get a treadmill. It's expensive and it takes up a lot of space. But these portable bikes, put it in front of the television set and do pedaling. I have an iPad and I watch Netflix on my treadmill. So it keeps me occupied. I do walking on the treadmill. But a stationary bike, you don't have to get these fancy bikes, these Peloton and stuff that cost maybe $1,000, etc. Stationary bikes maybe cost about $200, maybe a little less than that. And it gives you a lot of exercise for a short period of time. All right. Ciao.
Thank you very much, Dr. Girandola.
You're welcome.
Yeah, that was really an interesting presentation, a reminder to all of us as well on obesity, and also a reminder for us to actually keep moving on, around and make sure that we have incidental physical activity built into our everyday lives. So, ladies and gentlemen, moving on to our second speaker for today's session, which is Dr. Irena Aldhoon Hainerova. I hope I pronounced that right, who is a pediatrician in Prague, Czech Republic, and also a pediatric endocrinologist at the Birmingham Children's Hospital in the UK. She is a member of the editorial board of the International Journal of Obesity. Her research interests include monogenic forms of obesity, metabolic complications, and infectobesity. She has published one monography on childhood obesity and is also co-author of 10 other monographies. Dr. Hainerova will be speaking on endocrine disorders and physical activity. Dr. Hainerova, welcome, and may I hand over the session to you, and please make sure that your video is on, please.
Good morning, everyone. Good afternoon and good evening. Can you hear me? Can you just please confirm, please? Great. Thank you for the invitation. I would like to talk for a few minutes about the endocrine disorders and physical activity. So can I move the slides by myself? Just doesn't seem to work. Okay. So as we've heard, and we all know that physical activity is very essential for a healthy lifestyle. It's low cost, it doesn't cost anything if we just move, and it has a very big benefits for physical health and also psychological health. And it may also influence reproduction, for example. So my aims is to discuss the impact of hormonal impairment, disbalance on musculoskeletal system and physical performance. And I will also discuss responses to physical activity in patients with endocrine diseases. What are the endocrine glands? So we've got glands in our brain, as for example, pituitary gland. We've got thyroid gland, which is situated on the neck. We've got two adrenal glands on the top of kidneys. We've got pancreas with its insulin secretion, and we've got gonads, ovaries in females and testes in males. And all these glands are able to produce hormones which are essential for our body. The most common disorder is thyroid gland disorder. That's probably the most common endocrinopathy. So thyroid gland is on our neck. It has two lobes with an isthmus. It produces thyroid hormones, and it's regulated by our brain, by hypothalamus and anterior pituitary. The thyroid hormones has a very essential and very important role in growth, in central nervous system. It's very important for the development, maturation, and also a heart is a very sensitive organ to any changes of the thyroid hormones. It also impacts synthesis of proteins and carbohydrates and plays a role in lipid metabolism. You may come across of this diagnosis of congenital hypothyroidism. It's a diagnosis that is may be detected by newborn screening that is known in many countries. It's when it's left untreated, it has a very detrimental effect on growth and neuromotor development. As you may see, this little child has a protruded tongue, has umbilicus hernia, and also the development severely, the development is impaired. So, but when treated with thyroid hormones on time, it has a very good outcome. But still, when treated, it may also prevent the impairment of muscle strength. However, in some of patients with the congenital hypothyroidism, we see that they may show some poor postural control and also asymmetric plantar loading distribution. So, of course, supporting physical activity in these children is also very important to improve their body posture. Very common hypothyroidism for mostly the most common is because of autoimmunity. So you've got the thyroid gland itself is not able to produce enough of thyroid hormone. So you have low T4, but you have a high TSH, the hormone that comes from the brain, and these patients present with weight gain, they have constipation, they have a cool intolerance, poor appetite, and other impairments. Also, what we may see is that their muscle metabolism and exercise capacity is impaired because of impaired muscle metabolism, and also not supported by cardiovascular system. So they are known to have exercise intolerance. The exercise intolerance may not always be reversed by adequate hormone replacement, but it should be supported that these patients participate in regular physical activity and improve their life quality. Subclinical hypothyroidism is another entity. It's very much discussed within the endocrinologists, because it's you have a normal thyroid hormones, but the TSH, the hormone coming from brain, is still elevated. So the question is, should we treat these patients or should we not? So from the point of physical activity, and it has been shown that these patients demonstrate poor physical activity levels. They also have impairment of muscle metabolism, and they have decreased exercise tolerance capacity. They have also, they don't perform that well on the 6-minute walking test distance. They have they have decreased muscle strength. So these patients as well should participate in exercise programs to support their muscle strength and to to improve their exercise tolerance. And in one of those studies was showed that the levothyroxine, the hormone replacement, showed to improve the exercise performance with the treatment. Low T3 syndrome. So T3 is the active thyroid hormone, and we can come across to this diagnosis. It's maybe a response to starvation, malnutrition in those with a low calorie intake, especially those that have a low carbohydrate intake. Some patients with myocardial infarction may also have this low T3 syndrome, and it's associated with decreased energy expenditure and also impairs heart contractility. So it has patients with heart failure may have a adverse outcome while having the low T3 syndrome. The treatment for this would be to increase calorie and carbohydrate intake, and in some patients, especially those with heart failure, the T3 administration is recommended, and the exercise should be according to the cause of low T3 syndrome. On the other hand, much rarer diagnosis than the hypothyroidism is the thyrotoxicosis, or the hyperactive thyroid gland, where you have a lot of thyroid hormones produced by the thyroid gland, and you have suppressed TSH. These patients, mostly it is caused by so-called Graves' disease. So it's an autoimmune disease. It has a high recurrence rate. And these patients present with palpitations. They have difficulty sleeping, difficulties in concentrating. They have increased appetite, but they lose weight. So they have overall increased metabolic state, and there is a need for higher oxygen consumption. So it leads to increased cardiac output. And they have also exercise intolerance, which is due to the mitochondrial oxidative dysfunction because of increased intracellular acidosis. So in these patients, it's not recommended that they, at this time when they are not controlled, that they should exercise. So it is very important, if you have a patient that wants to exercise, to go through the medical history and to see, well, if the patient is not under control from the point of thyroid disease, shouldn't start to exercise at that point. Diabetes, just shortly, we know that physical activity, exercise is part of the recommendation. And I'm, as a pediatrician, mostly involved with type 1 diabetes, so patients that are insulin dependent, and either the insulin is delivered by the insulin pen, as you may see up here, or insulin pump, and of course they have to measure their blood glucose on daily basis, several times per day, either by the finger pricks or now the continuous glucose monitoring. So physical activities is part of the education. It's known that it improves overall glucose control, but it's recommended not to start to exercise if the blood sugar is above 14. At least that's what we say for the type 1 diabetic. They should always check blood sugar before exercising, and also recheck every 30 minutes while exercising, or if they kind of experience symptoms of low blood sugar, and they usually they have a good low blood sugar awareness, and those that don't, they know how to deal with it. They should also have low blood sugar treatment with them, either, as you may see here at the top, as a glucogel or glucotabs. So they should have this active fasting sugar with them while exercising. If we go to adrenal glands, so adrenal glands are glands that sit just at the top of kidneys. They are very important. You cannot live without adrenal glands because it's an organ that secretes mineral corticoids as aldosterone, glucocorticoids as cortisol, androgens, catecholamines, and others. And if we look at the endocrine conditions that can involve adrenal glands, it's either where you lack the hormones, so as a case of the Addison's disease, or so-called congenital adrenal hyperplasia, which is caused by lack of enzymes that produce cortisol. So these patients they have decreased, or they do not have any cortisol, and they have impairment of aldosterone secretion. On the other hand, they present as increased androgen secretion. Or the Addison disease, which is mostly later on as adolescents or adults. It's an autoimmune condition. They have antibodies against the adrenal glands that try to destroy the adrenal glands itself. And these patients may present with hypoglycemia because they lack cortisol. They have weight loss, they have hypertension, muscle weakness, and tiredness. On the other hand, you may come across Cushing syndrome. That's where you have increased production of cortisol. And these patients present with abdominal obesity, but very thin arms and legs. And they have kind of myopathy because of the increase of level of cortisol. And I will show that as well. So adrenal insufficiency, either because of the Addison's disease or because of this congenital adrenal hyperplasia, which is mostly diagnosed early on, should be diagnosed at during the newborn screening. These patients lack cortisol, so they are not able to respond their response during exercise is blunted with the rise in blood glucose. They also have their peak heart rate during exercise is lower. So, and we know that these patients are lifelong on hydrocortisone or any steroids for the whole life. They need to have so-called stress dosing, so they increase their hydrocortisone for some occasions, as for example, illness or fever or undergoing operation or surgery, whatever. The question is whether they should use this stress dosing while exercising, and few studies have kind of investigated that, and they found out that stress dosing for a short-term exercise is not beneficial, but it's of course questionable whether if it's a very strenuous and long-term exercise, whether any stress dosing, so increased dose of hydrocortisone or steroids, should be implemented for these individuals. Cushing syndromes, as I said, it has a visceral obesity. These patients are really at risk for cardiovascular diseases, and because of the high level of cortisol, they have sarcopenia. So they have atrophy of muscles on both extremities, lower and upper. They have reduction of exercise capacity even after long-term remission. And as you may see here on the at the bottom of the slide, the maximum aerobic capacity of patients, even after long-term remission, is much lower, significantly lower than the controls. And the study has investigated what is the reason, and they found it's not a difference. There is no difference in muscle fiber, but it's because of limited blood supply to the muscles because of cardiac dysfunction, which is known in these patients. We've got here Harvey Cushing's in 1932, the man that was was involved in this syndrome, and then also he was the one who found this corticosteroids-induced myopathy, which is an entity that can come patients can have if using steroids for any other reasons. And we know steroids long-term are used in many conditions, in renals, in liver, in rheumatology diseases. So this myopathy can occur. It's a kind of non-inflammatory myopathy. It presents with exercise intolerance, tiredness, muscle weakness, and it's because of most probably because of there is a limited blood supply, and its diagnosis can be confirmed if you start to taper steroids, that the muscle weakness improves, but also this improvement may take months to a year. It's been shown that the resistance and aerobic exercise can improve or even prevent this kind of steroid-induced myopathy. So again, physical activity in these patients may help in improving the myopathy and their problem. Let's talk about overtraining syndrome in athletes. So there have been, and I think you probably know more about this than myself, but there have been a lot of theories related to the cause. And one of the theory which is interesting is proposes that the state of high cortisol at the time of exercising or after the rest may be the cause of the overtraining syndrome. And it's we know once we exercise, our cortisol level goes up. It's because of the intensity as well as because of the stress itself. So as you can see here on the figure, the gray bar is the cortisol level of the Cushing's patients. The white dots is a control patients, and the one that goes up and down is the exercising individuals. And so the cortisol level at some point, even like 30 minutes after exercising, is as high as in the Cushing's patients. The only difference is that the exercising individuals, the high level of cortisol is only transient, and it goes down about 90 minutes after rest. Gonads, so ovaries in females and testes in males. So if we talk about testosterone, and we all know that the level of testosterone declines with age, It's very important hormone. It's crucial for both physiological exercise adaptation and safe sports participation. And we know that exercise can either positively or negatively influence andrological health status. It's dependent on the type of the physical activity, its intensity, in its duration, and of course, it's also based on the individual health status. Patients that do lack testosterone because of congenital hypogonadotropic hypogonadism, for example, caused by hypopituitarism, they are not able to produce testosterone, may have usually have decreased physical performance because of increased body fat, decreased muscle mass, and also decreased levels of hemoglobin concentration. So they have a lower oxygen supply to muscles, they have a poor glucose utilization, and also they lack out of this necessary aggressiveness for, let's say, sport participation and overall. We know that the testosterone replacement therapy, either we do give in our adolescents, either as an injection, monthly injection in intramuscular, or by a transdermal testosterone gel, can improve not only lipid and insulin metabolism, but also it leads to improvement in hemoglobin levels. It decreases fat deposits. It supports the growth of muscle fibers and increases lean mass, and also increases bone density. So these patients with a proper testosterone replacement therapy may increase their physical fitness, strength, and endurance. Talking about testosterone, I think I have to just shortly to talk about anabolic androgenic steroids. So what is their side effects? We know that they can disrupt actually male hypothalamic pituitary, and not only male, we'll talk about females later on, hypothalamic pituitary gonadal axis, and then results in hypogonadism and infertility. They also lead to lipid metabolism derangements, hypertension. They can lead to left ventricular hypertrophy, endothelial dysfunction, and coagulation disorders. Some studies, and these are just the studies that I've I'm referring, the bodybuilders that use these, for example, those that use these steroids have been observed to have high blood pressure, and it can lead to structural alterations in the heart. They are also known that there is a clear association with the use of anabolic androgenic steroids and cardiovascular diseases as myocardial infarction, fatal arrhythmias, or cardiomyopathy. And in bodybuilders using anabolic androgenic steroids, there was markedly increased risk of tendon ruptures. Females, if we take female fertility and physical activity, we know that regular physical activity has a positive effect on female fertility, and of course also on the offspring health, but it is dependent on exercise intensity because physical activity affects ovarian function in women. So we know that women that have a high intensity physical activity may have menstrual irregularities, and they are more common than in general population. There is also more commonly, we can see this functional hypothalamic amenorrhea, which is much more common in athletes than in non-athletic women. They have a high prevalence of anevolution and luteal phase deficiency. This hypothesis of critical fat, it says that you have to have a certain amount of fat, and I would guess it's about 40 kilograms for around 40-45 kilograms in order to be able to start puberty and also preserve your reproductive function. And so there is, from the adipose tissue, for example, leptin is the one that is able to kind of signal hypothalamic pituitary axis whether it's safe to start periods and also start a puberty itself. So high intensity physical activity can have a negative effect on human female fertility. On the other hand, the moderate and regular physical intensity improves female fertility. So talking about doping in women and its effect on ovarian function. So women, this is a very good, if you are interested, this is very good paper, kind of review paper on this, on the female fertility and also the doping on ovarian function. So they usually, use derivatives of testosterone, which have anabolic and masculinizing effects. Most commonly is use the oral oxandrolone, which has not as much, is not that androgenic as the other testosterone derivatives. And they, so what's the effect? Why to use those? It increase synthesis of proteins, and it also increase lean body mass, increase the oxygen transport, and also it has this kind of behavior effects, and it was shown that also it modulates some visual spatial cerebral activity. On the other hand, you have main side effects in women. It's the hypogonadotrophy, hypogonadism, menstrual irregularities. They can have clitoromegaly, baldness, hirsutism, deepening of voice, breast atrophy, but it's always dependent on the dose and duration. Shortly, hypoandrogenism in athletes. So it was found that in athletes, especially in the swimmers and the endurance athletes, they are found to have mild hypoandrogenism by itself without using any steroids. And they also have menstrual disorders. And very interestingly, they also have an ultrasound scan findings similar to the polycystic ovarian syndrome. So they have also polycystic ovaries, much higher prevalent incidence than in the general population. So in the athletes, if you come across a woman with period irregularities, either it's caused by the functional hypothalamic amenorrhea, and usually that's because insufficient dietary intake, insufficient body fat, and strenuous exercise, or, and that's more common, is because of the PCOS, so polycystic ovarian syndrome-like syndrome, with the hypoandrogenic, with the high levels of androgens. So this picture, they have higher testosterone, and these females have also higher body mass, higher bone mass density. They have more lean mass, and they have lower level of estrogens and estradiol. Interestingly, in 2011, in our IAAF World Championship in South Korea, they tested about 850 female athletes from over 160 countries, and they tested their testosterone and free testosterone. The median of the levels were much higher, where like was the 99th centile of sedentary women. So we know that the athletes have higher levels of testosterone, and especially the power disciplines had the highest. So the question is, what comes first? And we know that some of the athletes with period irregularities have also kind of history of higher frequency of delayed puberty. So the question is, because these girls start to train us from the young age, is it the hypoandrogenism? Is it a consequence of intensive training? It's still not clear. Interestingly, there was a study done in Poland on dancers that found even the dancers have frequently higher level testosterone levels, and especially in those with the lowest energy and carbohydrate intake. So the other question is it kind of protective mechanism against excessive weight loss? Because we know that testosterone stimulates the growth of lean tissue mass. We know that the elite athletes have higher testosterone level than the non-athletes. So the question is there any advantage in physical performance? And the answer is yes, it seems that those with the hyperandrogenic and the period irregularities or disorders perform better than those with the normal levels of testosterone, or the regular athletes with regular periods. Also, physical activity has a good impact on menopausal symptoms as hot flashes, mood swings, night sweat, and also the study showed that even community exercise can manage the vasomotor menopausal symptoms. Pituitary gland, a little gland that is situated in brain here, and one of the hormone that is produced is a growth hormone, and we know those that do not have deficiency in this hormone have impaired physical performance. They have lower exercise capacity. They have reduced availability of free fatty acids during exercise. They have decreased muscle strength, and even a short period of resistance exercise was able to improve the muscle strength in young male adults with a childhood onset of growth hormone deficiency. In elderly, and cardiac changes, so they have they seem to have a reduction in the left ventricle mass, and they have a left ventricle ejection fraction impairment, both at rest and at peak exercise. They have a shorter, they are able to, the duration of exercise is significantly shorter in those with growth hormone deficiency, and they have during exercise testing, they may have so-called ischemic like ST segment changes on ECG. So this may be explain the increased cardiovascular mortality in patients with growth hormone deficiency, maybe because of hyperpituitarism. On the other hand, the other extreme is when you have an excess of growth hormone, so-called acromegaly, mostly a diagnosis most commonly in adults because of pituitary adenoma. These patients have large hands, feet, they have problems with the joints, they have organomegaly, they have balance abnormalities, and again, even kind of physical activity rehabilitation should be implemented in the care of patients with acromegaly because it showed to improve the muscle function, functional capacity, and overall quality of life. And just to conclude, so you see that various endocrine disorders may be accompanied by exercise intolerance, and it's, I think, for anyone that has that meets patients should kind of see whether there is any endocrine disorder, at what stage is it under control, and kind of be aware that, for example, the most common thyroid disease, maybe they may have a normal cardiac function at rest, but may have problems while during exercise. Physical activity improves it may improve the physical fitness in some endocrine conditions, and for example in diabetic patients it's a must, it's a part of the treatment. I've shortly addressed the link, the physical activity and the fertility, how it's kind of that it may have even detrimental effect on fertility. So just overall, physical activity should be prescribed after an appropriate treatment of the disease, and of course, it always should be individually tailored. And by this, I would like to send you best regards from Prague and also from Birmingham, and I wish you all that you stay safe, and thank you again for invitation. If there are any so the question is, the short duration high cortisol level during overtraining harmful to the exercising individual? It seems it does. No, it seems it's not, because it's a short term. It seems within 90 minutes at rest, it seems to go down. So as a response, it seems it's not. Any for them to introduce exercise to, any protocol for them to introduce exercise to such type of person? With adrenal. Sorry, I didn't get any protocol for them to introduce exercise to such type of person. Is it which kind of person? If you can please text kind of that I can answer. And we will go area with adrenal gland function and uric acid. Actually, I'm not aware. Adrenal gland overfunction. So in Cushing's, because of obesity, I think they have a higher incidence of GOAT and increased uric acid because of obesity. I'm not aware of in those cases with insufficiency, but certainly with those with like Cushing's syndrome, yeah, they may have a higher incidence of increased level of uric acid and the associated complication. It can be different rate. So is the BM index can be different rate according to races? I think that's from the other speaker, but I can answer this, whether BM index can be different rate according to races. Yeah, I think that's a questionable. That's a question that we always ask. Should we use in especially Asian population different setting for the kind of criteria of overweight, obesity, and it's still not still we don't use it. But yeah, because we know as by the previous speaker was mentioned, still we don't have different cutoffs for overweight and obesity in different races. But it's a good point. So this question is, thank you for all the questions, saying as I said, if diabetic patients have a blood sugar more than 14, shouldn't exercise. Most diabetic patients in Malaysia tend to have very uncontrolled sugar levels, with a good majority of them being above 14 on random checks. What is your advice and recommendation for this group of patients in terms of exercise? Oh, thank you for this question. I think, I'm a pediatrician. Most of my patients are type 1 diabetic patients. So that's our recommendations for our patients. And of course, we always try that their blood sugar is more controlled. In terms of type 2 diabetic, it's very tricky. I have no experience with type 2 diabetic and exercising, and whether blood sugar 14 is something very common. I'm sad to hear that it is common, and I think it's just a good blood sugar control with, of course, physical activity. And I think it's from the diabetic diabetology, the endocrine specialists. They should tend to try to control their diabetes as much as well. But it's a good point, because our recommendation might mainly be for the type 1 diabetic and also children. Assume before exercise will affect female fat depends on can you say what appropriate intensity. I think intensity and female fertility, we see that this we see it's known that the irregularities with periods, delayed puberty, it's also for those the elite athletes, those that really have the strenuous training from early on. For general population, it's not the case that we would come across, unless you come across a patient with eating disorder or something like that. But it's really the high athletes, and it was in one of those slides, it was showed the elite athletes versus the non-elite athletes. That's where the difference is. So these disturbances really are for those that do really the sport on the top level, and not it doesn't apply for those in general population. Oh, what kind of hormone is suitable for long distance runners? I wouldn't recommend any hormones. I'm against any. I like to do hormone replacement therapy when the hormone is missing. That's my kind of duty as an endocrinologist. I'm really, and I try to show what is the adverse side effects of when you replace or when you give some hormones when it's not necessary. So I wouldn't recommend to give, and I, as an endocrinologist, I cannot recommend to give hormone when it's not missing. Sorry. I would like to ask, can we work out? So another question, whether we can work out during our menstrual cycle. Yes, I agree. We can. There is nothing that we can. Yes, it's as if you can you kind of do it safely and you feel right. No contraindication. Effect on. There is multiple hormone effect on obesity. There is multiple hormone effect on obesity. Thanks. Definitely. I mean, obesity itself, and I think that's for another lecture. I didn't want to address obesity as one. The hormonal disbalance in obesity in many ways, because of, for example, insulin resistance and other. They have a leptin resistance, so there is an effect of obesity. Definitely, and they have a higher degree of hypothyroidism, for example, as well. So yeah, obesity itself has a variety of hormonal disbalances. In women, very common is period abnormalities. Many obese even I have adolescents that are extremely obese and they don't have periods, they have secondary amenorrhea, and then later on problems conceiving, infertility because of polycystic ovarian syndrome. So obesity itself has is accompanied by many hormonal defects and abnormalities. Is that all right? Thank you for all the questions. I really appreciate. And again, thank you for the invitation to everyone to Malaysia. And I have a good day to all of you.
Thank you very much again, Dr. Hainerova. That was really an interesting session again, talking about the various types of endocrine disease disorders and the need to exercise or not, depending on the status of the conditions. We move on to our next speaker for today, who is from Brazil, Dr. Luis Paulo Gomes Mascarenhas, who is a professor at the State University of the Midwest in the Physical Education Department at the Irati campus, who has expertise in health, environment, and quality of life. He graduated in physical education and has a master's in physical activity and health, as well as a PhD in child and adolescent health. Dr. Mascarenhas is also the director of the Office of International Relations at Unicentro Brazil. He will be speaking on exercise and the pandemic. Please, over to you, Dr. Mascarenhas.
Hello, everybody. I'm Luis Mascarenhas from Brazil, and I'm from the University of Unicentro, and it's a pleasure to be here with you in the 4th World Conference in Exercise and Medicine in 2020. I will talk about exercise and nutrition and type 1 diabetes. Well, it's well known that the number of diabetes type 1 is rising around the world. And if you look here in this corner, you're gonna see that we have the incidences of diabetes in children around 0 to 14 years old, and also between 0 to 19 years old. It's rising around the world. So today I will talk to you a little bit about the relationship between physical activity and glucose metabolism for us to understand and to have an idea how the body works and dimension of the glucose in the body. And of course, care and a recommendation regards to insulin, carbohydrates, and hydration for type 1 diabetes when they are exercising. Well, it's important to know that to treat diabetes, we have 3 main points that's important. First of all, it's the use of the medicine, that's insulin. It's important also we control and have an understood about the food they are intake. And also it's very important understand how the exercise and physical activity it's involved in these other 2 issues. So it's not something new. Dr. Jones in 1951, they already said that it's very important for the treatment of the diabetes type 1. We introduce exercise in the equation. And of course, that it's important to understand that diabetes is something that's rising around the world, and 10% of total of diabetes that we have around the world, it's come from diabetes type 1. So it's very important for us to understand how to prescribe exercise in a safe way for this kind of population. Well, it's well important we understood how we can prescribe exercise. But before that, we need to understand what is the potential benefits, how is the potential motivator for the kids to do exercise, and of course, the big barriers that we have it. So, of course, the benefit of exercise is identical for everyone with disease or without the disease. And of course, the motivation is come from self-esteem, enjoyable social interaction, and of course, the health benefits that exercise comes with. But it's very important for us to understand that we have a lot of barriers that It's against us when they do exercise. And the most important of them is the fear of hypoglycemia. Most of the people or the person with diabetes type 1, they are afraid to have hypoglycemias during the exercise. It means that they avoided to do exercise to avoid to have hypoglycemias during the period of the treatment. Well, this is a study that we published recently that the physical activity levels in adolescents with type 1 diabetes. Of course, we have type 1 diabetes and a control group that doesn't have the illness. And it's very important for us, and you can see it here, that the physical activity level is low in patients with diabetes type 1. The sleeping time is also lower in type 1 diabetes. The time in sedentary activities are higher. And when you compare light and moderate vigorous physical activities, the diabetes type 1 are lower in these cases. And when you compare VO2 max, also type 1 diabetes has a lowest rate. What it's represent? It's represent that when you prescribe exercise, all this variable will be important for conducted the prescription of the exercise. And here, it's also a very interesting part of our research that we will split in diabetes type 1 with well-controlled diabetes with hemoglobin glycate under 7.5% and over 7.5%. And what you can see here, we can see that most of the people, most of the patients that has a good control, they are more activity. Or what that means, they exercise more and they are more acting during the day than those one with the worse control. What that means? That means that when we introduce exercise in the controlling of the day of the practice of the exercise for diabetes person, they had a better control of the illness. So it means that we can reduce the risk of the disease. Well, it's also important for us to understand how the physiological changes that diabetes occur in our bodies. So we have lower cardiorespiratory fitness, level of the heart rate at rest and exercise a little bit higher. We have also diastolic functions, reduction lactate synthetases, and the higher rate of perception extension. So when a person decides to do exercise or a patient decides to do exercise, it's very important for us to understand that all this come together with the diabetes disease. It means that you have to take care and pay attention in all these details that I told you before. Well, let's compare a little bit just to understand and to be in the same page. A regular person, a normal person without diabetes type 1, what's going to happen when they do exercise or when they exercise, the muscle will increase the glucose uptake, and the glucose in the blood will be a little going lower. And to support this lowest in the blood glucose, the insulin is going down and the counter-regulate hormones will raise it. And this change will bring us a normal glycemia. In the opposite way, in the other way, what's going to happen with diabetes person is the same thing. The glucose uptake raise, the glucose from the blood will go low, but because they use exogenous insulin, it's maintained the level of insulin higher. And also, this inhibits the counter-regulate hormones to work. It's driving the person who are diabetes doing exercise to have a higher risk of hypoglycemia. Well, what's going to happen during exercise? Let's get this example here. For example, during the exercise, our body will need, our muscle that's involved in moderate exercise, we need around 3 milligrams per kilogram per minute of glucose during the exercise. And when you stimulate the contrarregulate hormones, they will produce around 5 milligrams of per minute of glucose. It means that we have an equation here that your blood glucose goes down and then they move up a little bit, make the system equal. Well, what's happening with diabetes? The glucagon and the catecholamines doesn't work very well. It's mean that we don't have this kind of standardization here when the blood glucose goes down, and hypoglycemia must appear. Well know and well understand there's a little different between person with diabetes and person without diabetes as a physiological response to doing exercise. It's well important to know that the type of exercise, the intensity and the duration of exercise can drive the metabolic control for both sides, even to hypoglycemia as to higher hyperglycemia. So both things can happen in different types of exercise. Well, what you already know, we know that exercise and treatment imbalance. What that means, that exercise may change glucose homeostasis. Aerobic exercise may cause a reduction of plasma glucose, and anaerobic exercise can raise plasma blood glucose. What that means? That means that the type of exercise you choose for your patient to do it, you're gonna change the way the response of glucose in the body. So you have to be very aware which kind of exercise we are picking for which type of situation. We're gonna talk a little bit later about it. So what we can have in mind? So aerobic exercise is driving glucose trends to go down. When you have a mixed exercise, for example, when you play basketball, when you play volleyball, or when you play soccer, for example, there's a mix of anaerobic and aerobic exercise. The glucose trends can be or over or below the normal rate. But when you do anaerobic exercise, like for example, like you have like lift weight, or or you fight in martial arts, normally what's the tendency is that blood glucose is going to raise it because you're going to leave a lot of catecholamines in your body. Well, this is another studies very interesting that I would like to share with you guys. That is the quantified actually change in glucose with exercise in type 1 diabetes. This is a systematic review with a meta-analysis, and what we can show you here. And when you do continuous exercise, what means that when you stop the exercise in a continuous way of aerobic exercise, you're gonna have a low level of blood glucose. It means that you can put a blood glucose under 4.3 millimolars less. And when you stop the exercise between rests, you're gonna see it that during recovery time, the blood glucose is gonna raise a little bit, not too much, but raise a little bit, around 0.7 millimoles of liters per minute, per hour, sorry. But when you see a resistance training against continuous exercise, when you do anaerobic exercise, you're gonna see after exercise a raise around 2.86 millimoles per liter per hour. It means during recovery, the resistance training is going a little bit lower than they used to be before the exercise. It means that if you do continuous exercise, the tendency is that blood glucose is going down. But if you do an anaerobic exercise, it means that maybe your blood glucose is raising up. Well, what we can do and to avoid that that hypoglycemia can happen during the exercise with type 1 diabetes. Well, what you can do is you have to measure the blood glucose always before, during, and after exercise. If you do it before exercise and you found glycemia below 100 milligrams per deciliter. That means that it's very low. So you have to be careful. Look, the yellow sign here. But if the glycemia is between 100 and 30 milligrams per deciliter, it means that is a green area. So we can do exercise with some kind of no need happen. And of course, if you have a higher blood glucose over 300 milligrams per deciliter, you have to be careful. And what you can do it. For example, if you check the blood glucose and below 100 milligrams per deciliter, it means that you have to wait a little bit to start the exercise. You have to ingest around 15 grams of carbohydrates. It can be a fruit, can be a bar of cereal, something that we have in that. Wait a little bit for 15 to 20 minutes, and then you measure again. If the blood glucose goes up, it means that you can start the exercise without any further concerns. For example, if you are between 100 and 300, what is important? It's a safe range, so we can do exercise, no problem. The hypoglycemia could be not present during that amount of glycemia that you have it. But you have to pay attention, because after exercise, you may need to supplement a little bit of carbohydrates also. Well, let's see over 300, what they're gonna do it. Stop. Delay a little bit, they start the exercise. It's very important. We redouble the attention care with hydration. So it means we have to hydrate this person with water. I will talk a little bit later. But also we can do a ketoacidosis test. It means that if it's below 0.5, it means that the person can do exercise without any concerning. Well, this is very important for us to have an idea, but let's do a little bit further. How long after exercise does hypoglycemia is manifested? Well, it's important to understand that during exercise, maybe continuous aerobic exercise may make the hypoglycemia show up. Well, it's well known that after exercise, doesn't matter what kind of exercise you are doing, maybe you're gonna have the lowest value for blood glucose between 45 minutes and 90 minutes after the exercise. Wow, that's nice. And another time that we have to pay very attention is later of exercise. It's around 7 to 10 hours or 11 hours after exercise. What that means? That means that insulin sensitive is responding to the exercise and may increase the sensibility to insulin. What that means? That means that you're gonna use more glucose. More glucose is going inside the cell and be used, and it can drop the blood glucose very fast. So we have to pay attention in these 3 times of situation for avoid hypoglycemia. This is a very interesting study. That's the effective intensity of glucose requirement to maintain the glycemia during exercise. Look, I will explain very quickly for you that maybe lower like 35% of VO2 max, 50% of VO2 max, 60% of VO2 max, and 80% of VO2 max. What this study shows us that even for 1 hour or 2 hours after exercise, the amount of glucose can change because of the duration and the intensity. What that means? That means that at lower intensity and a higher intensity, we need around 2 milligrams to support the euglycemia during exercise. And during moderate exercise with 50 and 65, we need more, around 3 milligrams of glucose to support euglycemia during exercise in diabetes type 1. What that means? That glucose required to maintain stable euglycemia and exercise intensity is not linear, but follow an inverse U-curve relationship. What that means that maybe we need to adapt the amount of glucose that we need during exercise. It's up and come up to the intensity of the exercise. Well, what is well known, if you compare exercise doing in the morning and in the afternoon, what you're gonna see is less hypoglycemia happening during the morning exercise. Afternoon exercise has a characteristic to raise cortisol and maybe increase the amount of hypoglycemias that we have it in the afternoon. Well, the other important part is the hydration. When the glucose are very high in patients with diabetes type 1, it's very important to hydration. But you cannot drink water like if you want to need it all in one moment. What you need to do is small sweeps of water every 15 minutes, and it's important maybe to start that before the exercise, like 1 or 2 hours of hours before the exercise. Maybe you need 1 or 2 cups of water 10 or 15 minutes before the exercise, and then during whole time of exercise, between 10 to 20 minutes, you have to have small drinks of water during the time to make sure that you avoided ketosis during the exercise. Well, as I said, maybe you're gonna need to support a little bit of supplementation or with carbohydrates or isotonic drinks if the glycemia is going down very fast. Well, the other thing that is very important to, and normally we don't pay attention on that, is the rotation of insulin application. What that means? That means this, if the patient they apply the shot of insulin in the leg, we need to avoid to use the leg to do the main exercise muscle involved of the exercise. Why that? Because when you do exercise, we switch the muscles and the fibers, and that stimulate the GLUT4 protein that's taking glucose inside the cell, and also the insulin is doing that job. It means that when you have a shot in your leg and you do exercise with your leg also, you are increasing or double the amount of glucose that's going inside your cell. So to avoid hypoglycemia, it's very important to pay attention in the rotation and choose the right muscle to do the exercise in that time. Well, another thing that you must be attention, and maybe during the exercise, we need to suspend basal insulin, especially if the patient are using pump. So some recommendations that we have to finish our presentation here. Youth and adults with diabetes type 1 can benefit from being physical activity. That's very important. So we have a lot of benefits against low risks. Blood glucose response to physical activity or exercise in people with type 1 diabetes are highly variable based on the activity type and timing, and require different adjustments during that time. Additional carbohydrate intake or insulin reduce are typically required to maintain glycemic balance during and after physical activity. Insulin user can exercise use either bolus basal injection regime or insulin pumps, but there are advantages and disadvantages in both insulin delivery methods. Continuous glucose monitoring during physical activity can be used to detect hypoglycemia when used as adjusted rate than in place in capillary glucose tests. Well, another thing that's important for us and be attention in that time is that we have the pandemic, the COVID coming up. That's why we are talking here by online, not be present in the room, in the classroom, is to avoid COVID. And what you can see by the reports that older patients with type 1 diabetes compared to those with type 2 diabetes has more risk of mortality by COVID. So we need to pay attention. And one of the recommendations that we have to avoid the risk of COVID is encourage them to do physical activity in a cost of isolation constraints. So it's very important we stimulate and continue to do that physical activity even if we are in restricted contention. So take it home to safe drive for exercise. Evaluate the blood glucose before and after exercise. Intake of carbohydrate and water. And rotation and reducing fast-action insulin may be needed during the exercise. So pay attention in all of that. It's something that if you take it home, for me, it's very useful. I would like to thank you. This is my email. I would like to say thank you for the World Conference on Exercise and Medicine. I would like to thank you also my university, Unicentro. And to finish, I would like to thank you my student Gabriel Ribeiro for as a co-presentation of this study. Thank you very much. I appreciate. See you soon. Bye-bye.
Okay. Thank you very much to Dr. Mascarenhas for his presentation on exercise and pandemic, and especially looking into type 1, into diabetes. And yes, we need to actually be still doing our exercise, even though it's COVID. And I'm sure that some of us have benefited from the workshops that have been conducted. I think it was last 2 weeks where there was a demonstration on chair aerobics, which was really interesting, I think. Okay. All right. So any questions? We have, sorry, I think the connection with Dr. Mascarenhas is not good, but we have Dr. Hainerova, who's willing to actually answer some of the questions. So participants, you can post your questions in the question and answer tab. Thank you.
Can you hear me? Hello? Can you hear me?
Yes, Dr. Hainerova, we can hear you.
Yeah, sorry. I mean, I will try to answer some of the questions. I'm totally not prepared, but let's try. The best way of aerobic and anaerobic exercise combination for athlete to maintain blood glucose. Oh gosh, combination. I mean, I don't feel I mean, you are the experts for physical activity. I'm only the doctor on the other side that wants a patient that has a brilliant glucose control. And of course, as you've heard from the lecture, the ideal is the combination with the aerobic and anaerobic to prevent either the high blood sugar or low blood sugar. So I would say basketball, soccer, speed skating, skiing if you're if the country is allowed, rowing, gymnastics, running, middle distance running. So that would be probably those activities would be those that are able to combine aerobic and anaerobic type of activities. Are there specific meal types for diabetes patients? So if I talk about type 1 diabetic patients, nowadays, as we are really able to adjust, for our type 1 diabetic patients, we don't recommend any restrictions. Of course, they should not they should limit, they should kind of follow the healthy lifestyle. So limiting, McDonald's pizzas every day. So the really healthy lifestyle that we all should kind of follow. Because we are able to adjust the insulins based on the carb ratio, and of course they have to count their carbs intake. So that's the need for the good control. With the type 2 diabetic, it's different. It's mostly obese patients where you have to be very strict. You have to try to not only kind of limit carbohydrate intake, but especially fat intake, and, do all these as with other obese patients. But for type 1 diabetes, from my experience at the moment, as we are able really to adjust, if they are know how to do a good carb counting, we can say no limitation, but still they have to follow healthy lifestyle and limit the sugary. They shouldn't drink the sugary fizzy drinks and these things. Can you elaborate on how to select an portion aerobic or resistance exercise for type 1 diabetic patients? So what is the portion? I guess I'm not able to answer apart from the combination seems to work the best for these patients, but what portion, I think if you want to maybe to kind of email Dr. Paulo to answer this question. What type of exercise is recommended to diabetic? I think that's what's said, and it was in the lecture. The combination of the aerobic and anaerobic seems to be the best, because the blood sugar with these type of exercises remains more or less the same. As we know, anaerobic tends to lead to increased blood sugar. On the other hand, aerobic patients seem to have kind of the blood sugar seems to drop. Yeah, and that's it for the question. What I can see, I'm really sorry, yeah, that's it. I was not prepared for answering these questions. I would suggest, if you have any questions related to the topic and to Dr. Paulo's lecture, please.
Okay, thank you very much, Dr. Hainerova, for trying to answer some of those questions. Yeah, participants who are interested to actually get feedback or answers to your questions can, I suppose, email Dr. Mascarenhas on his email. I think that was shared on his last slide. Okay, perhaps we just move on to our fourth speaker for today, Dr. Arto Pesola, who is a research manager at the Active Life Lab, Southeastern Finland University of Applied Sciences in Mikkeli, Finland. He is currently involved in two major studies, one focusing on muscle activity and health in type 2 diabetic patients, and another one on effects of free bus rides on children's sedentary time. He was an expert member for the Finnish Ministry of Social Affairs and Health Working Group on Finnish sedentary behavior recommendations previously, and has been awarded the Young Investigator Award in Biomedicine by the Finnish Society of Sports Sciences in 2017. Dr. Pesola will be speaking on a very interesting topic. Is breaking up sitting a waste of time for physically active people? Please, Dr. Pesola, this session is yours.
Your Royal Highness, Mr. Prime Minister, dear Chairman Dr. Lei, ladies and gentlemen, my name is Arto Pesola, and today I want to talk to you about a topic which is very familiar for many of us. At least myself, I love doing sports. I go running every now and then, play padel, ice hockey, and I consider myself pretty much as a physically active person. However, despite all of these activities, I may find myself sitting the most of my days. Ironically, I might be so interested in my research about physically active lifestyle that I didn't even notice myself doing exactly the opposite thing, just sitting down. Now, as a physical activity researcher, this paradigm has fascinated me a lot from academic perspective, but also from health promotion point of view. So if I'm doing exercise on most of the days, does it actually even matter if I'm sitting down at my work and non-work time? To explore this further, it's good to take a look at the basics. So what is sedentary behavior and why would it be bad for health at the first place? Sedentary behavior is defined as a seated or lying posture while awake, expending little energy. Basically, the most common form of sedentary behavior is sitting, whereas standing up from a chair activates muscles, increases energy expenditure, and is no longer defined as sedentary behavior. At the core of sedentary behavior is lack of muscle activity. Here's a short video showing how active our muscles are during daily activities, or actually how passive they can be. When we are sitting, there's basically no activity in our muscles, as you can see from the figure. Small ambulation can add up to the activity, but basically, during sitting, our muscles are idle. Standing up from the chair, on the other hand, is a very powerful means to increase muscle activity. Standing still is also active, but because the lower extremity muscles need to keep us in an upright posture. Walking is a very good dynamic source of activity, and when you add up some squats or calf raises where you need to work against gravity, you can see that the effect at the muscle level is huge. Metabolic rate of skeletal muscle changes in a greater rate than in any other tissue type in the human body. At rest, the metabolic rate is quite low, but it can rise up to 50 to 100-fold immediately upon activation. Here on the left, you can see me wearing all these devices we have been using, and as you probably can see, I'm wearing a pair of very tight shorts which measure my left and right hamstring and quadriceps muscle activity level. So we have asked participants to wear these shorts for 1 to 3 days during their normal daily life, and most of them have agreed to do so. And in this other picture, you can see how inactive and active our muscles are during everyday life, and more specifically, how much variation there is between individuals. So everything below this line is muscle inactivity, and on average, muscles were inactive for 65% of the day, and more intensive activities covered only a small proportion of the days. The mean EMG amplitude was only 3% of the maximal voluntary contractile capacity. Now, considering today's topic, what do you think? Are physically active people more likely at this side of the graph where there is less muscle inactivity? So do you think that physically active people who exercise are actually more active on average during their daily lives? The answer, perhaps surprisingly, is no. Those who are physically active are actually sitting exactly as much as those who are exercising. So spending about 150 minutes per week in moderate to vigorous physical activities, which equals meeting the physical activity guidelines, does not reduce the daily time spent sitting. In our study, we compared marathon runners on the right to recreational exercisers and those who are inactive, and we found out again that even though only 4% of marathon runners did not meet the current physical activity guidelines, they were sitting exactly as much as inactive adults, of whom only 65% met the guidelines. Of whom actually 65% didn't meet the guidelines. So therefore, exercise for fitness does not make you sit less. In other words, breaking up or reducing sitting is as much needed as a behavior by those who exercise and by those who don't. Now we come to an even more important question. So, does sitting matter in terms of health for those who are physically active? In a large harmonized meta-analysis by Eklund and others, which was using self-reported data, active individuals, shown here on orange, were found to achieve an additional 10 to 12% reduction in all-cause mortality risk if reducing their total daily sitting time from more than 8 hours to less than 4 hours per day. The effect was even larger in those who were inactive. However, in those who were active, exercising 60 minutes per day, the effects of sitting on all-cause mortality were attenuated. Based on this highly cited study, the level of moderate to vigorous physical activity modifies the effect of sitting time on health, in this case on all-cause mortality. In our study, on the other hand, we showed that within a sample of physically active people, those who have a low muscle inactivity time have a more beneficial HDL and triglyceride cholesterol concentration, HDL cholesterol and triglyceride concentration, as compared to those who had a high muscle inactivity time. And therefore, it seems that activating large muscle groups on a regular basis is very important for health, even in those who are active. Another emerging concept to evaluate the risks of sitting is to measure how total sitting time is accumulated. In these figures, you can see two different scenarios on this. So both of these scenarios have the same duration of physical activity, but on the left side, sitting time is accumulated in prolonged continuous bouts, whereas on the right side, sitting is accumulated in short bouts. There are some recent papers showing that accumulating sitting time in prolonged continuous bouts, like on the left, actually makes the risks of total sitting time worse, like those risks that are related to cardiometabolic risk biomarkers and all-cause mortality. Yet it still remains unknown if physical activity mitigates the risks of prolonged sitting accumulation. We decided to explore this in a total of 685 healthy men and women from the 2011 to 2012 AusDiab study sample, and we defined a high moderate to vigorous activity level by having more than 300 minutes per week of measured moderate to vigorous physical activity. So in these figures, at top you can see the inactive adults, and at the bottom the active adults, and on the left you can see so-called prolongers who have like prolonged sitting accumulation patterns, and on the right side you can see the breakers who have a more fragmented sitting accumulation. This paper is still under preparation, but the results show that all adults, regardless of activity level, can benefit from a more fragmented sitting accumulation regarding waist circumference, triglycerides, fasting plasma glucose, HbA1c, as well as post-load glucose concentration. The only biomarker that benefited from a more fragmented sitting only in inactive adults was HDL cholesterol. So therefore, breaking up sitting seems to benefit everyone regardless of the activity level. This topic is very timely because the new physical activity guidelines for the first time state that shifting from sitting to being more active would have significant health benefits for many people. There is increasing evidence showing that replacing sitting with moderate vigorous intensity physical activity in particular is beneficial for nearly everyone. Moreover, as discussed today, there is some preliminary evidence to show that accumulating sitting time in shorter rather than in longer continuous bouts is beneficial also for those who are highly active. Therefore, you are likely to get benefits from breaking up sitting even if you have a high physical activity level. And this is an important message to all of us who feel being physically active but who find ourselves sitting all day at our screens. I want to thank you all for your attention, and here I want to show you that I'm very proud of my Twitter profile picture which I got a year ago in Kuala Lumpur in World Congress on Exercise Medicine 2019 Congress. So I want to thank you all for the opportunity to be involved and hope to see you again soon in person. Meanwhile, please feel free to contact me, for example, through these channels in here. And I also want to point to you into Physical Activity Researcher podcast, where my friend and colleague Olli Tikkanen hosts world-renowned researchers as guests. And from that podcast, you will learn a lot about physical activity and sedentary behavior in an entertaining way. Now, I think it's a good time to stand up. Thank you. Okay, it seems that I got the first question here. So, is physically active couch potato can stay being couch potato if they maintain exercise routine? So physical activity and sedentary time are different things, and therefore, even though you exercise, you can be considered as couch potato. And I think this concept has changed throughout the years, because now we have more and more evidence about the risks of sitting, even in those who are physically active. So you can remain as a couch potato even if you exercise. So it's good to sit less, even if you are active otherwise. Any suggestions to burn calories while sitting in front of the screen? Yeah, there are many ways how you can increase calorie expenditure, but I would say that already standing up increases your muscle activity considerably, but I think it's also good to consider this from behavioral point of view. So, like moving your legs while watching television might not be a long-term solution. It's not very motivating. So I think it would be much better to have an exercise you like, go out with your friends, play with your kids. And these are activities which are necessarily not moderate to vigorous intensity, but they may still reduce the time spent sitting and be motivating at the same time. So how do we identify which type of physical exercise boosts our metabolic rate the best? Well, all types of exercise will affect your metabolism, and generally speaking, the energy expenditure of the activity is the most important defining thing in here. So the more intense exercise, the better it boosts your metabolism in a given period of time. And higher intensity exercise have also after exercise elevated after exercise energy expenditure. But again, in the long run, I think it's very important that the exercise or physical activity is frequent. So if you exercise only during the weekends, you get less benefits than if you spread the exercise or activity throughout the week. Thank you for the good presentation. You're welcome. It's good to hear. So I would like to ask, after what duration of sitting that you would suggest for us to get up and move? Especially if those who need to work in front of the screens. Yeah, this is a good question, and I think there's not a definitive answer for this, but it's very safe to say that standing up every half an hour would be very beneficial. And if that's not feasible, then every once in an hour is also very good. There's some preliminary evidence showing that standing, if you sit for 3 hours continuously and then have a bout of exercise, you don't get as good benefits for insulin sensitivity than breaking up sitting every half an hour, even though you had the same amount of exercise. So the frequent breaks are important. So you would suggest for us to get and move, especially those who need to work in front of the screen. Yeah, perhaps bunkers or writers. Yeah, if you really don't have an opportunity to stand up, I think then it's good to exercise before or right after the sitting bout, or be active before and after the sitting bout. And this is the most beneficial when it's close to the dinner time or lunch time. So if you have exercise before lunch or after lunch, you get the best benefits per time unit for glucose tolerance, for example. And what is your recommendation for sedentary workers who may have difficulty to avoid sitting? This is very important and good question. So my recommendation would be to break up sitting as much as possible. And if you really cannot reduce or break up sitting, then it's very important to remain active and keep fit. So increase your fitness level and have meet the physical activity recommendations with moderate to vigorous activity. So you can reduce the risks of sitting by exercising, but it's even better if you can do both exercise and reduce and break up sitting. How much energy expenditure just when sitting? Yeah, basically, it's about 1 kilocalorie per kilogram in an hour, which is our basic energy expenditure level. But it's important to note that regarding the risks of sitting are mostly related to muscle inactivity and muscle metabolism or lack of muscle metabolism. So the basal metabolic rate is a little bit different concept than energy expenditure during sitting. So I would more like to talk more about activating your muscles and increasing your energy expenditure through physical activity, because muscle activation is kind of the signal for improved metabolic outcomes. What are your advice on chair aerobic exercise? So I think you refer to, you mean for chairing aerobic exercises during seminars, for example. Well, I think as a chair or organizing committee, I think it's very important to take care of the breaks and provide exercises like in this seminar as well. And it's regarding sitting, the behavioral concept is very strong. We are used to sitting down, and we have environments which make us sit like office environments. So that's why even if we are not intervened on breaking up sitting, then we will just sit down because the environment is made for sitting. And it's the same for online meetings and congresses. So that's why it's very important for the organizing committee to tell participants to stand up and provide advice and guidance on activities. And this is where you are doing very good in this one. It is very good. What's your opinion on using inclined sitting workstation for office work? So I'm not quite sure what kind of is inclined sitting workstation, but sit-stand workstations are very good. And there are many kind of different workstations available. But the most important thing is to break up sitting, stand up regularly, and also break up prolonged standing periods as well. So dynamic activities every now and then, which break up either standing or sitting periods, are the best option, regardless of the workstation you are using. Thank you for all. It was very nice to be involved, and have a very active rest of the Congress.
Thank you very much, Dr. Pesola. Yes, I agree. We should be walking the talk and have mobility breaks apart from our usual exercise sessions, whether it's in the morning or in the afternoon. And I agree, it's quite challenging when you have long meetings or conferences like this. But we should really try, actually. I know that in the previous world conferences in Malaysia, we did have mobility breaks. So we look forward to that in the future. So anyhow, we come now to the last speaker for this session today. Ladies and gentlemen, may I introduce Dr. Raven Lee Kian Leong, who is a medical doctor at Monspace Medical Clinic, Malaysia. Dr. Lee is a member of the International Scientific Committee on Exercise Medicine and also of the Malaysian Crisis Preparedness and Response Center. He is also a volunteer for Mercy Malaysia. Dr. Lee will be presenting on non-communicable diseases and exercise. So Raven, I hand over the session to you.
Thank you so much, Dr. Norhayati, for the kind introduction. So today, my presentation would be about non-communicable diseases and exercise. So what is non-communicable diseases, or known as NCD? They're basically diseases that are not transmissible. So they're not a virus or bacteria. They're basically diseases such as hypertension, diabetes, cancer, chronic lung diseases, and even obesity. So NCD is one of the highest diagnosed collection of diseases in the world. Like I mentioned earlier, so these are the basic lists of some of the NCDs that we have around, which cardiovascular diseases, diabetes, cancer, and also chronic obstructive pulmonary diseases, which are basically chronic lung diseases. So if we look at, this is the stats from the WHO website for Malaysia. if you can look at it, NCD accounts for about 74% of deaths in Malaysia, with cardiovascular diseases topping them at 35%. Cancer at 16, chronic respiratory diseases at 14, and diabetes at 3. Although you might think that diabetes only accounts for 3% of deaths, the complication that arises from diabetes is actually pretty bad, and probably just as bad as the mortality rates around. Oops. Can't seem to skip my slide. Right. So when we talk about NCDs, we need to look at the risk factors that come with NCDs. Until today, doctors and scientists around the world can't actually point out the finger as to what actually causes diseases, non-communicable diseases, NCD. But we have pointed out risk factors. So what are risk factors? So risk factors are basically factors that can cause factors that can cause leading up to non-communicable diseases. So some of them are genetics. For example, poor family history. So if you have grandparents or parents who have heart problems or hypertension or diabetes, there's a very good chance you might have it, or even the next few generations might have it. Diet control is another risk factor we have to look at. In Malaysia, especially, you know, we're known as one of the countries famous for our food, and that is also another problem, along with obesity, poor lifestyle practices such as consumption of tobacco and also alcohol intake. Physical inactivity is also another problem around the world. They're mostly seen in more advanced countries where, you know, everybody works in offices and companies, and not so much like in the other lesser developed countries in Southeast Asia, such as like Vietnam and Cambodia. They tend to have a bit more physical activity going on compared to more advanced countries. The other two risk factors I would like to look at are poor medical treatment, which comprises of poor compliance and poor access. So poor compliance meaning a patient who has been diagnosed by his doctor to be hypertensive or diabetic, you know, they go for their first treatment, you know, they get their medications, they do their blood works. However, you know, they don't have, they don't go for their follow-up treatments. They might miss maybe their appointment in a month or 2 months, which means they might not have sufficient medication to get them through the period where they don't see the doctor. So this could be due to usually in the more rural areas of a country where medical access is also quite a problem. Culture and socio-economic group also plays a very vital factor because in the lesser, poorer socio-economic groups, for example, if you listen to Dr. Robert's lecture earlier, he mentioned that in Mississippi, where it's one of the poorest countries around, you know, they tend to eat unhealthy food, you know, buy chips, and because they don't have access to maybe healthy food like in the supermarket and so on and so forth. So today I'll be covering two main non-communicable disease, which is basically hypertension and diabetes. And then we'll talk about how exercise can actually help combat these two issues. So we'll start with hypertension. So hypertension is actually one of the most diagnosed diseases around here in Malaysia and also worldwide. What is hypertension? It's basically high blood pressure, where your systolic reading is above 140 millimeter mole mercury, and your diastolic reading of over 90. However, if you were to diagnose someone as hypertension, it would be best to take an average of at least 2 or more readings, because if you're going to diagnose someone based on one reading, there is a very high likelihood that could be a misdiagnosis, because if a person were to go to his doctor for a routine checkup, you know, for example, you know, the traffic might be bad, the weather might be hot, he might have trouble looking for parking spaces for his car. So these are all stresses which can actually elevate your blood pressure. So if the doctor is going to diagnose you for hypertension based on all those stress factors that has led to the increase of blood pressure, he's going to start you on a medication, and in 2 weeks you're going to come back and see him with, you know, dizziness and headache because of the medication that makes you now hypotensive with much lower blood pressure. So hypertension, there are two types: primary hypertension and secondary hypertension. In terms of non-communicable diseases, we're going to look at primary hypertension only, which is also known as essential hypertension, and is also occurs for about 95% of all hypertensive cases. Why I'm not talking about secondary hypertension? Because it is not so much of a non-communicable disease. It could be due to an underlying disease that is causing the spike in blood pressure. For example, maybe there's a tumor sitting on your adrenal gland that causes hypersecretion of hormones, which could actually create rise in blood pressure. So if we just quickly look at the classification of hypertension, you have normal patients where their systolic reading is less than 120 and the diastolic is less than 80. You have the pre-hypertension, which is the systolic reading between 120 to 139. And then you have your stage 1 and stage 2 hypertension. When you look at this classification at this table, in terms of exercise, the group that we should really focus on are the pre-hypertensive patients, because at this stage, that person who is pre-hypertensive does not have hypertension yet. However, he would run the risk of developing hypertension in maybe the next 5 years or even 10 years. Why I say that this group is the most crucial group, because if you can prevent these group from developing hypertension, that would save a lot of money, a lot of time, and basically improving the quality of life. So in stage 1 hypertension, patients are usually on maybe 1 or 2 hypertensive medication. However, if they're in stage 2, then most likely they'll be on combination treatments, probably on ACE treatments and calcium channel blockers, or even beta blockers, or even thiazides in some cases. So let's look at the signs and symptoms of hypertension. So first and foremost, you will and always have asymptomatic patients, who have high blood pressure, but they don't have any of the symptoms such as dizziness, headaches, neck pain, and fatigue. Neck pain is actually one very classical symptom of blood pressure, high blood pressure. Most patients actually don't even know how to describe the neck pain. They just grab their neck and then they'll tell the doctor that it feels very uncomfortable. The problem with these symptoms of hypertension is they're all very non-specific symptoms. You could have a headache from really bad weather or from stress. You could have neck pain from sleeping in the wrong position. You could have fatigue from overexerting yourself if you went for futsal, if you were doing some house chores and whatnot. So the problem with these symptoms are they're all non-specific symptoms. If you look at the last two symptoms, which is shortness of breath, nausea, and vomiting, these symptoms will only show in the later stage of hypertension, when the blood pressure, the BP is reading about 180 to 190 to 200 for the systolic reading. So the problem with hypertension, it comes together with various complications. So the most common complication patients usually end up with poorly controlled blood pressure is stroke. And then they come with heart attacks and heart failure. But they usually begin with impaired vision. They will come and they will tell the doctor that their eyesight has been bad for the past few months. It's been getting worse. So these are all the first telltale signs of someone who is actually probably developing hypertension. And then also you have kidney injury. This kidney injury might take maybe 5, 10, even 20 years for it to be in the final stages where the patient would actually need dialysis. So patient evaluation objective. So you have a patient who is hypertensive. The first thing you should always do is assess the lifestyle and identify other cardiovascular risk factors or concomitant disorders that may affect the prognosis or treatment. That means you have to assess the patient's lifestyle. You have to speak to him, find out if he's eating healthy, if he's leading a sedentary lifestyle, if he has any activities planned for the weekend. And also you need to find out about his socioeconomic status. If he's poor, follow-ups with the doctor will be a problem for him, and things like that. You also have to reveal identifiable causes of high blood pressure. For example, sometimes one of the main stresses for high blood pressure is stress from work. So this could also be another one of the causes that you have to identify. And then finally, when you have a patient who is hypertensive, you must always assess the patient if there is any presence of target organ damage. So basically what target organ damage is, the complications of hypertension, they affect a few organs. If you look at it, it affects the brain, it affects the heart, it affects the eyes, it affects the kidney. So these are all target organs. So if you assess a patient medically, we have to assess them to see if the kidney has any problem, any injury to the kidney, any changes in an electrocardiogram, blood works for his kidney, and definitely checking his eyesight if to see he needs a referral to the eye specialist. So management. When it comes to non-communicable diseases, there's always two forms of management. So the first one being pharmacological intervention. So this is basically medication. There are many types of antihypertensive medication. You have, like I mentioned earlier, you have your ACE inhibitors, you have your calcium channel blockers, you have your beta blockers, you have your ARBs, you have your diuretics. So the type of treatment depends on the patient, and it depends on the assessment of the physician. So I'll give you an example. If you have an 80-year-old woman who is, bedbound, she can't walk, or she's always, bedbound basically, you can't give her an antihypertensive like a diuretic. Basically, a diuretic is a type of antihypertensive that will cause you to excrete fluid, in other words, to urinate. So if a patient is bedbound, unable to move, so that wouldn't be the first choice of medication. So it really depends on the discrepancy and the assessment of the assessing physician. The second thing is lifestyle modification. So we have to assess if the patient is eating healthy, is he taking too much salty food, is he getting enough exercise, and so on. So exercise. A couple of weeks ago, during I think the first or the second week of the conference, one of the questions for the speakers was, is housework, considered exercise? There's a lot of patients in the rural areas. They think that doing house chores such as gardening and cleaning after the house, that is exercise. So let's define exercise. All right. So the definition of exercise is the right dosage of voluntary muscular contraction with a specific dedicated time frame. That means you have to set a time for exercise. It's not something that you have to do every day like a house chore. No, it is not. Number two, the dosage. You have to exercise appropriately according to your dosage, because if you exercise with the wrong dosage, for example, if you are able to exercise in a very comfortable intensity, then you're just wasting your time. However, if you go to the gym, you lift weights, and you don't know what your dosage is, and you end up, lifting more than you should, you run the risk of injuring yourself from exercising. And in exercise, you need voluntary muscular contraction, which means every movement must be voluntary and with the command from the brain. That means, for example, it is not a chore. It has to be something that must be voluntary. For example, resistance training, like if you're doing a bicep curl. So that movement itself is voluntary. And finally, a dedicated time frame. So a time frame must be allocated for. So you could either work out, 2 times a week or even 3 times a week. So if you have hypertension or diabetes or any underlying medical illness for the matter, the dosage is very important, because if a person is hypertensive or has any other underlying medical issues, if you do not get the right dosage, you might actually be putting yourself more at risk of developing other complications by exercising too hard or even exercising too lightly. So as a prescription, the dosage must be individualized based on a thorough assessment. So when I said a thorough assessment, it means, height, BMI, weight, skin fold test, cardiac test, stamina test, a proper full-on assessment. So there are a few questions I would like to answer today. So let's look at a few questions. Does exercise reduce blood pressure? If yes, What type of exercise reduces blood pressure? If no, is exercising safe for hypertensive patients? What is exercise hypertension? And finally, is exercise hypertension safe? All right. As a medical doctor, you get a lot of patients, especially those who are not so educated. They've come with me with questions like, oh, doctor, I have high blood pressure for the past 10 years. My friends have advised me not to exercise because if I exercise, my blood pressure will go up even more because you're exerting. Is that safe? I don't want to get a stroke from exercising. So let's clear this. Let's get the elephant out of the room, all right? So the first paper I'd like to share with you all, it's an amazing paper. It's called Exercise-Induced Hypertension. So if you look at this slide again, the fourth question, what is exercise hypertension? So this paper explains what is exercise hypertension. So if you exercise, if you exert yourself, it is a normal physiologic response for your blood pressure to elevate because you're exerting, all right? However, if after exercise, the blood pressure, your systolic blood pressure reaches more than 210 millimeter mercury for male or more than 190 millimeter mercury for female, this is not normal, right? So if you exercise and you're a male and after exercise, your systolic reading reads more than 210, this is an abnormal response to exercise. It shouldn't be that high. So if it reads this high, it could be number one, that could be, and you could have an underlying cardiac disease that you never knew about, or you might even be hypertensive. You might have had high blood pressure for the past maybe couple of weeks, couple of months, and you've never had any symptoms. So to achieve, to have a systolic reading of 210 for males and more than 190 for females with light or moderate intensity of exercise is not a normal physiological response. If you do exercise and you get this increased elevation of systolic blood pressure, please go see your doctor, all right? So having said that, what is exercise hypertension? So basically exercise hypertension is the increase of your systolic blood pressure where it goes more than 210 for male and 190 millimeter mercury for women. Is exercise hypertension safe? It is safe if it does not exceed the figures I mentioned, 210 millimeter mercury for men and 190 for women. Number two, resistance training reduces systolic blood pressure in metabolic syndrome. Why I'd like to share this paper is very simple, because when you advise patients, or when I advise patients to exercise, they're always going for the basics, which is, walking, jogging, yoga. However, they don't realize the importance of resistance training, for example, weightlifting. There's a preconceived notion that, if you go work out with weights and do resistance training, you're going to bulk up. I've had many female patients, who come to me and tell me that, they don't want to use weights and do resistance training because they don't want to bulk up and, be all muscular. If you're going to work out at 3 times a week, resistance training at weights that you're pretty comfortable with, it is almost impossible to build a body like the bodybuilders. Anyway, to get back to this paper, the take-home points from this paper is that resistance training is an effective and low-cost method in treating cardiovascular diseases and non-communicable diseases. Why? Because all you need are some weights. If you don't have weights, you can fill up water bottles with water and use them as weights, all right? The other take-home point is that there is an inverse association between muscular strength and the incidence of metabolic disease. So if you have increased muscular strength, you have a lower risk of developing these metabolic diseases. Resistance training reduces systolic blood pressure by approximately 4.1 millimeter mercury. So you might think that a reduction of 4.1 isn't actually that great. However, there was another paper done by Lewington et al. That paper proved that a reduction of just 2 millimeter mercury can reduce stroke by 10% and mortalities from heart disease by 7%. This paper studies the acute effects of exercise on blood pressure. So this is another paper on why you should exercise. And the take-home points from this paper was that the higher the age of the participant, the lower the reduction in diastolic blood pressure. Males achieved greater reductions in blood pressure readings than female. Reduction in blood pressure was greater if the exercise was performed as a preventive strategy and in physically active individuals who have not yet been medicated. Lower BMI was associated with greater reduction in systolic blood pressure. So this paper simply means start exercising young when you're healthy. Do not wait till you're well into your 40s or 50s, or do not wait until you've been diagnosed with hypertension or diabetes and then start working out. This paper simply proves start early and prevent it. Now we'll look at diabetes mellitus, type 2. I know the first two presentations have been type 1, so we'll look at type 2 right now. So basically, type 2 diabetes is basically a metabolic disease which results in abnormally high sugar levels, where the fasting blood sugar reads more than 7 millimoles per liter. So this is just the basic plasma insulin cycle. So as you can see at 8 a.m., there's a spike in insulin because you've had your breakfast, and then you've had your noon spike from lunch, and then your spike at 6 p.m. from your dinner. So basically this spike is in a cycle that responds to your meal intake. So let's look at the signs and symptoms of diabetes. So a diabetic patient will always have increased thirst, polydipsia, polyphagia, and also polyuria. Blurring of vision is also a very common symptom, but the problem with blurring of vision is as you grow older, as patients grow older, their vision will deteriorate irregardless. So this symptom is very often overlooked. If you look at the last one, which is the slow healing of wounds, this is one of the reasons why you come across diabetic patients who have their feet amputated, sometimes below the ankle, sometimes above the ankle, sometimes it's below the knee, sometimes it's above the knee. The other more serious signs and symptoms in the more advanced stage of diabetes, which means really high blood glucose levels, would be nausea, vomiting, unconsciousness, confusion, and also ultimately brain damage. So let's look at the complications that come with diabetes. So if you look at the bottom of the graph here, the A1C percentage. So A1C percentage is basically the average sugar in a person's body for the past 3 months. So if you look at the light blue one, which is the highest, that is the retinopathy, which is basically complications involving your eyes. And then secondly, the red one, nephropathy, which is complications with your kidneys. The green one, third, neuropathy, which is basically complications affecting your nerves. And finally, microalbuminuria. So microalbuminuria is basically tiny particles of protein which sort of escape from your kidneys into your urine. So microalbuminuria is actually one of the earliest signs of kidney failures. So if we look at the complications a little bit closer, if you're diabetic, you have a double risk for cardiovascular diseases, 75%. So when we worry about diabetes and cardiovascular disease, we worry about the silent MI, basically a silent myocardial infarction. What a silent myocardial infarction is basically, diabetic patients will not feel or experience the classical chest pain that normal people would if they had a heart attack. So they wouldn't have the chest pain that's radiating to the left side of the shoulder, The reason why they do not feel this pain is because of the nerves which are involving the cardiac afferent nerves have been damaged, which is very similar as to why diabetic patients tend to have a lot of cases of amputation, because the nerves on their foot, basically it's numb. So whatever wound they have on their foot, they won't feel it. And the problem is when a patient has high sugar in their blood, high glucose, it disrupts the function of the white blood cells. So white blood cells are basically your blood cells which fight infection. When there's high glucose, it disrupts this. And also if you're diabetic, there's poor circulation. So all of these actually attribute to all the amputation cases that you see. And then the third complication, diabetic nephropathy, which is basically a complication involving your kidneys. So the early signs for this is microalbuminuria, like I mentioned, to check for proteins in your urine. So diabetic patients would regularly need to undergo this urine test. If it is not monitored, if it's not taken care of, then they run the risk of end-stage renal disease and then needing dialysis. And then finally, diabetic retinopathy, which is basically complications involving the eye. It always starts with worsening of vision, blurring of vision, and then in worst case scenarios, the patient could go blind due to retinal detachment. So if we look at the management, it is the same for hypertension. You have your pharmacological intervention and also your lifestyle modification. So in pharmacological, you have your oral anti-hyperglycemic agents, which is like basically your tablets, your metformins, your glibenclamides, your glycosides. And then if those oral tablets do not control your sugar, then the physician will move on to insulin injections. And then, of course, diabetic patients would always need to watch their diet, to avoid meals high in carbs and sugar. So why is exercise important for diabetic patients? It's because when you exercise, you increase insulin sensitivity, you decrease insulin resistance, and it can lower blood glucose for up to 24 hours after you exercise. It increases the use of bloodstream in your, it increases the use of glucose in your bloodstream, ultimately reducing HbA1c. So if we look at this paper on exercise and type 2 diabetes, the conclusions from this paper is pretty conclusive. It talks about contracting muscles, increasing the uptake of blood glucose, because early in your exercise, your glycogen is first used as fuel. But as your glycogen depletes, the muscles start to increase their uptake and start using circulating blood glucose and free fatty acids. These muscular blood glucose uptake remains elevated post-exercise, contraction-mediated pathway persisting for several hours. Resistance training results in lower fasting blood glucose for at least 24 hours post-exercise for individuals with impaired fasting glucose. Of course, diabetic patients also run the risk of exercise-induced hypoglycemia, but the risk here is minimal. So if you have a diabetic patient who wants to go for exercise, so you have to adhere to certain safety protocols. For example, if a patient is diabetic, it is always a good thing to check his random blood glucose before performing an exercise, like previously mentioned by our last two speakers. So once again, if you're diabetic, resistance training is imperative. The combination with cardio training, it is imperative. You need both, because one will give you the best of acute effects, and then one will give you the best of the chronic effects in terms of reducing blood sugar. However, I cannot stress enough that if you're diabetic, if you're hypertensive, if you have any, cardiac or any underlying medical issues, if you exercise, it has to be prescribed. When I say prescribed, the dosage has to be the right dosage. So in order, to make sure that you exercise safely and you do not experience any discomfort after you exercise. So the take-home message from today's presentation is that exercise can reduce blood pressure and improve blood glucose levels. The results depend on the type of exercise you do, the intensity and dosage, which brings me on to the third point, dosage. Always exercise at the prescribed dosage so you don't overwork yourself or you don't underwork yourself. The combination of aerobic and resistance training yields better reductions in blood pressure and blood glucose. Exercise yields better results in healthy individuals compared to individuals who already have a condition, which means, start early. Prevention is always better than cure. Individuals suffering from NCD should be monitored by qualified personnel when they're exercising. Thank you. I have one question. What exercises can you recommend if a person just experienced mild stroke and speech and facial are affected? Okay, so if a person has experienced mild stroke, it would be best to be assessed first. I cannot, just give you a type of exercise off the bat, based on speech and facial, but because it really depends on the severity of the stroke. Some patients, just have very minimal loss of power, some, complete loss of power. So it really depends on the condition of the patient and how bad it is. If a patient is having NCD, how many percentage does exercise help in management as compared to drug management? Okay. Number one, nothing will ever replace pharmacological intervention, because it depends on how bad and the severity of the patient's condition is. A proper advice, I would say you need both. You need medication as well as regular exercise. When I say regular exercise, I'm suggesting, at something between 2 to 3 times a week. You need both. You can't just have one and not have the other. How to manage medication along with exercise routine for diabetes type 1 patient? Okay, it's a very good question. Okay, if you're dealing with a patient who has type 1 diabetes or even type 2, or in fact, any other underlying medical illness, the best would be to liaise with the doctor who is attending your patient. So when I say liaise, I mean, so when your patient is under a follow-up at a clinic and he comes to you for exercise, train him based on the dosage. Always record his blood pressure before and after. If he's diabetic, his fasting, his random blood sugar before and after. Document it and then write in a memo or a letter and pass it to the patient, so the patient can bring it to his doctor, and then the doctor can actually look to see as to how much the exercises help. If the exercises really helped him, then maybe the doctor can reduce his dosage of medication. If not, to increase it. How is the dosage being described? What are the considerations and formula in deciding how much dosage is suitable for an individual? Right. Also a very good question. So when we talk about dosage, like I mentioned earlier, a patient has to be assessed, a thorough assessment. I can't say how much dosage is suitable for an individual, because every individual is different. Even like in a Dr. Hainerova speech, a lecture earlier, she said, all exercises has to be tailored. So I would suggest you to find an exercise center to have a patient assessed and to get all the parameters taken into consideration before prescribing an exercise. What is the best ratio of resistance and cardiovascular exercise? So, thank you, Dr. Lim. You need both. You need both. So 50-50, definitely. You need both for the best of both worlds. In your opinion, who should be qualified to prescribe the right dosage of exercise to patients with hypertension and diabetes? Also a very good question. So as of right now, the government, the Malaysian government, the Ministry of Health, they have endorsed exercise therapists, so they're certified to assess a patient and to prescribe the right dosage of exercise in terms of patient is hypertensive or even diabetic. When I say properly qualified, meaning someone who's actually gone through a full certification course, like a diploma or degree, not someone who's, just certified over a couple of weeks of, online courses. How do you determine the exercise dosage? What are the parameters you will consider when describing exercise dosage? Once again, there's a lot of questions on dosage, which is fair. It is imperative to ensure you have the right dosage, but like I said, you have to go to the right place and have the right people. The dosage depends on the patient's physical assessment. If his blood pressure is high, if his sugar is well controlled, if he has no underlying cardiac conditions, his ECGs are clean. Skin fold test to determine fat, how fat the patient is or obese. Wishing to ask if we should tighten medication for diabetics pre-exercise or just allow them to follow their common regimen. I'm assuming this Mr. Kevin Trianto wishing to ask if we should tighten medications for diabetes pre-exercise. So to tighten medication, you have to be a medical doctor. So I'm assuming you're a medical doctor. So having said that, if you have a patient who is undergoing a exercise regimen outside or at home, it would be best if you can ask that person to record his blood pressure before, his pulse and blood pressure before and after exercise, as well as his sugar levels before and after, so that when the patient comes back to you for the follow-up, you can actually look at the readings and then you can decide if the dosage has to be decreased or even increased. What are the criteria of exercise prescription? So basically, once again, to prescribe exercise, to get the right dosage, that the patient has to undergo a thorough physical assessment, like I mentioned earlier. We do it here. We do it at MS New Symphony Exercise Clinic, where we assess the patient's, their blood pressure, their sugar. If the patient has a referral letter or from a medical doctor, that would be great. That would give us some more background as to what the patient is undergoing. So that would help us to tailor a dosage or prescription for the patient. What is my opinion of patients or people that are made to exercise as compared to those who are willing to exercise when we gave them appointment to come? Okay. The thing about exercise is, it takes a lot of discipline because it can be a bit tedious and a bit boring because it's quite repetitive. But my opinion on this is that you can't force someone to do something they don't want to do. So my advice would be to advise the patients, to advise people, give them the adequate knowledge so that they know, such as, the complications of certain disease that could arise if it is not treated. Well, it depends. If a person is willing to exercise and he knows it's important, then he would do it. If he's not unable to come to the facility to exercise for whatever reason, then you really can't force people to do something they don't want to do. So my advice would be to educate them thoroughly and appropriately. What type of exercise can be prescribed for type 2 diabetes patients with OA of knees? Very good questions. So like I mentioned, you need both cardio exercises and also the resistance training. So if a patient who has osteoarthritis of both his knees, then I would maybe recommend staying away from things like walking and jogging, and move towards something such as resistance training, like weights training, the use of dumbbells, it doesn't have to be very heavy. Like once again, the dosage, the weightage, the poundage of the dumbbell it says for the resistance training has to be the right poundage. There's a lot of questions. Does the medication need to take continuously for hypertension? Because right. So basically, this question asks is if diabetic and hypertensive patient has to be taken continuously. They were worried about the side effects. Yeah, I agree. Some medication yields certain side effects to certain patients, but once again, like I said, you have to educate your patients. In terms of the complications that arise. The complications from the diseases left untreated is worse than the complications from the medications used to treat very basic stuff like diabetes and hypertension, especially in the early stages. You're on very common medication that really won't have side effects to worry about, so to speak. Who should be qualified to prescribe the right dosage? Yeah, so I've answered this earlier. So basically someone who's qualified. The Ministry of Health in Malaysia, so they endorse exercise therapists. So they've had 3 to 4 years of diploma. So they're qualified to assess a patient and to prescribe exercise. Oh, that was it. Thank you very much. If you have any questions, you can always email me at ravenlee87@gmail.com. Thank you.
Okay, so thank you very much, Raven, and that brings us to the end of today's session. We've covered quite a few topics, ranging from obesity, endocrine diseases, diabetes, and NCDs, and the need for exercise or physical activity, as well as some of the safety measures and guidelines, I guess, when we're dealing with such patients. And it's also important to remember that apart from exercising, we also need to consider sitting down for long periods of time, or rather the need to actually have mobility breaks to get up from sitting down too long. So, ladies and gentlemen, may I remind you as well that today's session has been awarded CPD points by the Allied Health Sciences Department, Ministry of Health, Malaysia. So, points awarded for today's session is 4. And I would like to once again thank Dr. Lee and to all our speakers for the session today. Please join us again tomorrow at the same time at 1500 hours Malaysian time for the session on exercise and social aspects. Till then, a very good day to all of you, and see you all again tomorrow. Bye.